Right. Is everyone here? All good. Guys, turn your cameras on. Let me see your faces after about a week. Okay, so I changed the setting a little today. Easy access to the board, right? Guys, can everyone hear me? All good? Thumbs up? Yeah? Okay. Right, give me a second. Right, so today we are going to talk about hemolytic anemias. Hemolytic anemias. Now, let me share the screen. What do you all know about hemolytic anemias or hemolysis before we go on to our chapter? What do you all know? Anything you all know about hemolytic anemias? Anyone? What do you all know about hemolytic anemia? Since I think what, third year you all must have done? Tarinder, Sachit? There we go. Right, I can see you all now. Anything? No? Guys, okay, tell me this. What do you all think is the definition of hemolysis? What is hemolysis?
Breakdown of RBC.
Breakdown of RBCs. Now, hemolysis itself, the word hemolysis itself, is it a pathology? Is hemolysis a disease?
No.
No, right? Hemolysis is not a disease. Hemolysis is a general physiological process. It's the breakdown of RBCs, right? What becomes the pathology is once we start hemolyzing or breaking down RBCs at a rate that cannot be compensated, that we cannot produce new RBCs. That's when we start manifesting anemia. That's when we start manifesting anemia. So this is what we are going to talk about today, hemolytic anemia, right? Okay. Now look at this in your note, guys. I've just put this table directly from Davidson's. So here, in this table, as you can see, the hemolytic anemias, guys, it can be broken down into inherited and acquired, right? Inherited means some sort of genetic defect, right? Acquired is what you gain throughout life, right? So the inherited ones, now if you take a look at those, we have discussed all of those, right? The inherited forms of hemolysis, we have discussed all of these, right? All done. So today we are going to pay special attention to these acquired forms. And out of that also, guys, we are going to we are going to make a great emphasis on the immune one, on these immune forms, right, of hemolytic anemias, right? The non-immune ones, we'll just mention a little, right? These ones, most of them come under other chapters, guys. We'll talk about them, TTP, hemolytic uremic syndrome, right? DIC, we'll talk about those separately. And some of them we'll just mention, they're just, even PNH, you all have already done, right? So today our main focus is acquired type of hemolytic anemias and specifically the immune forms, right? This is what we are mainly going to talk about today, right? So let's get into it, right? Now, you all can put the topic, hemolytic anemia, right? Okay. Here, guys, now before we go on to the pathology, we'll look at the basic physiology a little, right? Physiology, right? Basically, what is happening in a normal person when we have RBC breakdown. Now, some part of this we have already discussed. We'll just go through it again. You all know where are RBCs produced, guys? Mainly in bone marrow, in the bones, right? Bone marrow. That also mainly in red bone marrow, right? Red bone marrow, you all know, specifically when you're like in adulthood, these are mainly present in flat bones, and some long bones as well. What do we have, guys, here? Just basically, we are not going into the details. We have the stem cells, right? Okay, and from that, what do we have? We have something called myeloid stem cells, right? We have another line called lymphoid. right? These are the basic two lines, right? Cell lines, lineages. From the myeloid series, we leave the lymphoid aside. From the myeloid is where we get three others, right? One is erythrocyte, erythroid, right? And megakaryocytic series, right? The other one is granulocyte monocyte series, right? And the other one is the basophilic series, right? Right? Now from here, out of this erythroid series is where we get our hematopoiesis, right? Our erythropoiesis, right? What is going to happen? We talked about this in our thalassemia class, in our iron deficiency anemia class, right? If you all remember that picture, what is happening? Little by little, cell size reducing, right? We have the erythroblast, right? We have the erythroblast, early normoblast, late normoblast, like that, a reticulocyte, and finally erythrocyte. Even little by little, what is happening? With the cell divisions, the cell size gets smaller and smaller and smaller, right? And if you all remember, in the reticulocyte, right? And then the last one is the mature RBC, that is the smallest one, right? So we have discussed all of this. Now, with that, you all can draw a blood vessel somewhere here, right? What is happening? This blood cell final product comes here into the blood. It will be pumped into the circulation, right? So we have a nice RBC, right? With some nice hemoglobin and some central pallor. Now, what is the lifespan of an RBC, guys? This is about 120 days, right? After this 120 days, what happens to this RBC? Huh? What happens to this RBC?
Remove it.
Yes, spleen will remove it. But why? Why 120 days? Why does this lifespan? Why is the lifespan so short? Why within 120 days?
There's no nucleus.
Excellent. There is no nucleus. RBC, the mature RBC, does not have a nucleus. So what is the problem? It is unable to synthesize new proteins, right? It is unable to synthesize new proteins. So what is going to happen? By about 120 days, all their proteinaceous structures start getting denatured, right? And they cannot be replaced, right? For example, guys, if you all want some detail, right? You look at the RBC, it looks something like this. On the membrane, guys, here, there are some special protein structures. Some are horizontal, like the ones I have drawn in green, and then there are some vertical ones like this as well, right? These give support to the RBC membrane. Now, why does the RBC membrane need this much of support? Why? It has to squeeze through tiny vessels, tiny capillaries, and go throughout the circulation, especially when it comes to the spleen. We will see, right, in today's physiology. In the spleen, there are some tiny blood vessels. Through these, the RBC should be able to squeeze and pass through. So these are, guys, there are some proteins, right? We don't need to know the details. There are some spectrines, right? Spectrine, some actins, right? Some anchyrins, right? These are all, right? I don't want you all to remember these names. Just remember there are something, these are what we call cytoskeletal proteins, right? So what is happening? This RBC has some cytoskeletal proteins that give support to the membrane. And since there is no nucleus, right, with time, right, as these cytoskeletal proteins get denatured, there is no replacement of them, right? No replacement, no new cytoskeletal proteins being produced, right? So what do they do? What do these do, right? They give flexibility to the RBC, right? Okay. Right. Now look at this, guys. Towards the end of the 120 days, towards the end of its life cycle, towards the end of the 120 days, two things happen. One thing is what we already talked about, cytoskeletal proteins denatured, right? And they cannot be replaced because there's no nucleus. This is one thing that happens, right? So what is going to happen? Flexibility is lost, right? And RBC membrane stability lost. Stability lost. What do we mean by the stability, guys? We know the RBC's membrane is holding this nice biconcave disc-like shape, right? This shape is also maintained by these cytoskeletal proteins. Now, what is going to happen when these denature? What can happen? We lose the biconcave shape, right? Biconcave shape. Okay, and it becomes more of a spherical shape, right? Then another thing that happens with this membrane destruction by the nearing the 120 days, another thing, guys, you all know all our cellular membranes, they have various pumps. What is one of the most important pump? Sodium, right? So in the same way, these RBCs also, they also have some sodium pumps. What is going to happen with this membrane dysfunction, guys? These sodium pumps also become dysfunctional. Sodium pumps become dysfunctional. Therefore, what happens, guys? Sodium starts accumulating within the RBC. Now, when sodium accumulates somewhere, what does it attract? What does it attract usually? Water, right? So what is going to happen? Osmotic gradient, down the osmotic potential, right? Water starts moving in, right? And what is going to happen? Again, we are going to have some swelling, right? And together with the destability of the membrane, it is going to again aid in this formation of a much more globular shape or a spherical shape of an RBC, right? These are things that happen towards the end of the lifespan, right? So biconcavity is lost, right? Biconcavity is lost, right? Now, this loss of biconcavity is important. Huh? We'll see what is happening next, right? So this is the first stage. We can say this as the first stage towards the 120 days. This is what is happening. Then now we'll see what is the next step. Did you all write it down? Right? Just loss of biconcavity. Yeah. So one way is the cytoskeletal proteins being denatured. Other one, the sodium pumps being dysfunctional. Right? Loss of biconcavity. Right. Okay. Right. Now we'll continue from there, right? We'll draw the second diagram. What did we have? Now we have the RBC that is quite old. 120 days have been reached, right? 120 days, right? What is going to happen, guys? These RBCs, they pass through all our body tissue. So one particular tissue it passes through is our spleen. It passes through our spleen. Let's see what happens when it enters the spleen, right? The RBC enters the spleen. Here, guys, in the spleen, right? You can draw a little bit of a big spleen. In the spleen, guys, the vasculature is very special. It separates into tiny blood vessels, guys, right? Separates into tiny blood vessels that we call these tiny blood vessels cords of Billroth, right? Cords of Billroth, right? These are called cords. These are actually blood vessels, but they're so tiny, they're so thin that they're called cords, right? Cords of Billroth, right? Now, if we take a zoomed in view of one of these cords, right? One of these cords, will zoom it in a little bit, right? This is going to look something like this, guys. It is basically a capillary system. It's like a fenestrated capillary. It is something like this. And here we have endothelial cells, right? Okay. So this vessel looks something like this. The cords of Billroth. It has tiny gaps. Right? Okay. Now look at this, guys. Because of this particular structure in the cords of Billroth, they act sort of like a selective barrier. What do I mean by that? Look at this. If our young RBCs come here, right? Now, if our young RBCs come here, guys, in order to do the oxygen transport and everything, they will leak out through these, right? And here, somewhere here, we have the tissue fluid in the surrounding area, right? We have the tissues and we have the venous systems, right? We have the venous system. So what is special about this splenic blood transport is, guys, blood cells need to come out of the cords of Billroth in the spleen and then enter the venous system, right? That is the special thing about this blood transport in the spleen. So because of this, the cords of Billroth, they act sort of like a selective barrier. What do I mean by that? Look at this. Now, let's say a young RBC. I will draw it. I will draw these cords of Billroth in black so that it's clearer, right? And the RBC in red, right? Look at this. Let's say a young RBC came here. What does a young RBC have? A nice biconcave disc shape. Nice biconcave disc shape. When the young RBC comes, it can easily flex, because it is very flexible. It can flex through these cords, through the fenestrations of cords of Billroth and get out, right? And get out. And then it can do whatever function. If it wants to supply oxygen, it can supply the oxygen, gas exchange, do all that, then get back into the venous system, right? And leave, right? No problem, right? Then let's see what happens when a little bit of an old RBC comes. Now, what is the general shape of the old RBC? We don't have a name for the general shape. We cannot say it is definitely globular. But what do we know for sure? Definitely not a biconcave disc, right? It is not a biconcave disc and it is not very flexible. It is not very flexible. So this old fellow comes here, guys. Now this is an old fellow, old RBC, and he tries his best to get through this. What happens? He gets stuck there, right? Old RBCs, they will get stuck, right? In the cords of Billroth, right? They will get stuck in the fenestrations of the cords of Billroth. Okay, right? So they will try their best. Maybe a little piece will come out, but the rest won't go. Huh? They cannot squeeze through these structures and leave. Huh? Now, here's the other important factor about these cords of Billroth. Who is standing in between these cords of Billroth? Right, you all can draw something like this. Some faces. Who are these? Who are these? These are, guys, macrophages, right? Macrophages are staying out with their mouths open on the sides of the cords of Billroth, right? Splenic macrophages. So what happens, guys? Whoever comes and gets stuck here, what will happen? Macrophage will come and start eating them up, right? Okay. Did everyone understand? So this is why we said the cords of Billroth of the spleen, the very tiny blood vessels, they act sort of like a selective barrier to weed out the old blood vessels from the new ones, right? Okay. Right? There is no special mechanism to detect 120-day blood vessels. They don't have an ID card. They won't come and show the birthday and all of that, right? What happens? Naturally, they come and get stuck. Okay, they come and get stuck there. Right? Right. Then the next step you all already know. What is happening once we'll go through it anyways. Once the macrophage engulfs inside the macrophage, what is happening, right? We have already talked about this in the iron deficiency anemia class, right? So you all can draw a large macrophage somewhere there, right? Okay, and you all can draw blood vessels somewhere here. What is happening, guys? Now the RBC has been engulfed. This is now, we can say, the stage 3. What is happening? RBC has been engulfed into this macrophage, right? RBC has been engulfed into this macrophage, right? We know as the RBC begins breaking down, right? We have cytoplasmic components and we have membrane components, right? The cytoplasmic components, guys, sorry, we'll start off with the membrane ones. membrane ones, we can have lipids from the phospholipid layers, right? Lipids, right? We can have certain proteins. The lipids, we know they will go to form fatty acids, right? The proteins, we know they will go to form amino acids, right? Amino acids, end of the day, right? In the cytoplasm, again, we get some proteins, right? Cytoplasmic proteins, they will also be broken down further into amino acids. But what is the important thing in the cytoplasm? We have hemoglobin, right? HB, right? Right. Hemoglobin is broken down into what? Now unmute and tell me. We have already talked about this. But easy. What are these?
Hemoglobin.
Heme and globin. Heme, in heme, what is the form of iron, guys? What is the form of iron in heme? Ferrous, Fe2 plus, right? Fe2 plus, I hope you all remember, right? So these heme will be broken down further into what? Into what? Do you all remember? Into two things.
Protoporphyrin.
Now here's the thing, guys. The protoporphyrin, that is the ring structure, right? The protoporphyrin is the ring structure. Once we disassemble that ring structure, do you all remember we drew something like this? We said the ring is going to be flattened out, right? Right? Something like this. What is this structure called? What is this called?
Biliverdin.
Biliverdin. This is called biliverdin. So we have biliverdin, and plus what else do we get? We get the heme iron. If you all remember last time also we drew the heme iron in red color. So I will use the same thing. This is what? This is Fe2 plus. Fe2 plus. Right? Heme iron. Right? Then, right? What we'll leave this biliverdin for a little bit. What happens to this free Fe2 plus, guys? Is it allowed to stay in this free Fe2 plus form? What happens? What happens immediately? Excellent. Apoferritin. Excellent. The nucleus of these macrophages, they are able to code for a special protein, right? This protein is called apoferritin. And apoferritin will be packaged with this Fe2 plus, right? To form what we call ferritin. Now, if you all remember, in ferritin, what is the form of iron? What is the form of iron? Ferric form, Fe2 plus. And we have talked about all of this. And then depending on the body's requirement, guys, what did we say? Either this ferritin can be pumped into the blood, or if there is a storage requirement, that means if the body already has enough of iron, what will happen? These will aggregate. Ferritins will aggregate, right? Forming another molecule, which we called as hemosiderin. Right? This is a larger molecule, right? We have talked about all of these, right? Hemosiderin, right? I hope you all remember. Okay, so we'll leave that there, right? Today, our discussion is focused on this other part, starting from this biliverdin pathway. What is happening here? Because this is where the hemolysis is happening, right? Last time we talked about the iron metabolism, right? Look at this. Biliverdin, guys. Look at this. Biliverdin inside the macrophage, it meets with a special enzyme, guys, right? Through this enzyme, this biliverdin is converted to bilirubin. Bilirubin, I will put it in a purple B, purple letter B. Bilirubin. What is this enzyme, guys? Nothing much. This is called biliverdin reductase, right? Biliverdin reductase. Okay, biliverdin reductase. Now this bilirubin that was formed in this macrophage, guys, what do you all think? Is it conjugated bilirubin or unconjugated bilirubin? Unconjugated. Now we will see next. For bilirubin to be conjugated, guys, it has to go to the liver and undergo another reaction. We'll see what that is, right? So for now, just know this is, y'all can put it in brackets, unconjugated. What is another name for unconjugated bilirubin?
Indirect.
Indirect. Now these terms, guys, these are important. Why? In certain questions, they will tell you as unconjugated. In another question, it will come, the word will come indirect. So you should know both, right? We will see. I have put some questions today. We will do that towards the end, right? Anyway, so we have formed now unconjugated bilirubin, right? This bilirubin, guys, right? This is a tiny molecule, right? It comes into the blood, right? Look at this. So we will put the bilirubin here, purple B, it comes into the blood, right? And since it is very tiny, it has a strong tendency to leak out from the blood into the tissue fluid, right? Now, our body does not want that happening. Our body does not want that happening. So our body has created a mechanism to stop that, to stop these bilirubin being leaked out from the vasculature to the extracellular fluid. Look at this. So what I will draw on this side is a liver, right? Right, a nice liver, right? Liver, huh? Right. Now, what happens, guys? Since this bilirubin has a tendency to leak out, our body will bind it, right, with something that won't easily leak out of blood vessels, right? Unless, of course, there is a pathology, right? Now, when I say like that, what do you all think that molecule is? During certain renal pathology, especially, that substance can leak out, but on other cases, it tends to almost never leak out. What is that? Yeah. Something that if it leaks into tissue fluid, it can give rise to edemas. What is it? Something that can leak out through urine when there is a glomerular disease.
Albumin.
Albumin. Okay, right, good, right. What happens, guys? Our liver, you all know our liver is capable of producing albumin, right? So what happens? This albumin that is in blood, right, likes to bind with this bilirubin, right? Something like this. So this is a bilirubin albumin complex. Now, will this easily leak out of blood vessels? Will this easy? No, almost never, unless of course there is some underlying other pathology, right? That is causing increased leaking out of material from the blood, right? Unless that is there, this bilirubin won't leak out. So now nicely through the vasculature, this bilirubin can be transported, right? With albumin, right? Albumin. It will be transported, guys. The bilirubin eventually comes to the liver, right? It will be transported to the liver, right? From the spleen, it came to the blood. From the blood, now it will go into the liver. What is this bilirubin? Unconjugated bilirubin, right? Okay, unconjugated bilirubin coming with the albumin, together with the albumin. Now, in the liver, what is happening? In the liver, guys, we have our hepatocytes, right? I will just draw a rough sketch. These are some hepatocytes, right? Hepatocytes, like this, right? The hepatocytes, guys, they have the receptor for this bilirubin albumin complex. So you can draw it something like that. They have this receptor, right? They have a nice receptor for this bilirubin albumin complex to come and bind. So what will happen? That complex will come and bind to these hepatocytes. And eventually, through endocytotic processes, they will be taken in, right? And inside, they will be packed into a lysosome, right? We don't need to talk about this. Eventually, the free bilirubin, unconjugated bilirubin, will now enter the hepatocyte. Unconjugated bilirubin enters the hepatocyte, right? Right. Then what happens next in this hepatocyte? In this hepatocyte, now we know these hepatocytes, guys, just like any other cell, they have all these cellular structures. They have Golgi apparatus, they have endoplasmic reticulum, right? Or mitochondria, all of these are there, right? In the endoplasmic reticulum, guys, right? In the endoplasmic reticulums, right? ER of these hepatocytes, ER of the hepatocytes, there is another special enzyme, right? So what do we have here? We have the unconjugated bilirubin. with the help of the enzymes on this ER, it will be converted to conjugated bilirubin, right? This is what conjugated bilirubin. Conjugated bilirubin, right? The B with a small circle, okay? Conjugated bilirubin, right? What is this? What is happening here? What is happening here is, guys, there is an enzyme called, write this down, this enzyme that is working here, right? This is called UDP, right? Very complex name, glucuronide transferase, right? There is nothing special here, guys. There is a group called glucuronide. The bilirubin is bound with that, right? The bilirubin is bound with that glucuronide group, right? That is all that is happening. And this is why, so this is, what is the end result, guys? Conjugated bilirubin. Conjugated bilirubin. What is another name for this? What is another name for this? Direct.
Direct.
Right? Yes. Direct bilirubin. What is another name for it? Bilirubin. Write it down. Bilirubin glucuronide. Glucuronide. Same thing. All three are the same thing. Right? Okay. This enzyme, all that it does is it transfers a glucuronide group onto the bilirubin. That is what we call conjugated bilirubin. Okay, conjugated bilirubin. Right? Same thing. Conjugated bilirubin, direct bilirubin, right? Bilirubin glucuronide, same substance they are talking about. Okay. Right? Okay. So now what did we do? From the spleen, we got unconjugated bilirubin. From the RBC breakdown, that unconjugated bilirubin with the help of albumin came to the liver. In the liver, that unconjugated bilirubin was now conjugated, which means we just added a glucuronide group. So now we are having conjugated bilirubin, right? Now what happens next? If you all remember, guys, the structure, within our liver, we have this thing called our biliary tree, right? Our biliary tree, right? There is, which aids the bile flow all throughout these hepatocytes, right? They share this pathway. It's like a tree, right? Towards the end, what do we have, right? We have two ducts coming together, right? And it comes down, right? Somewhere here, we have a structure like this. Okay, let me draw that properly. Like that. Our gallbladder, right? And then here we have the pancreas, right? We don't need to draw those. Here, eventually it enters the second part of the duodenum, right? We'll talk about that part later, right? Right? Basically, what I want to show is our biliary tree, right? Okay. Now what happens, guys? This, our conjugated bilirubin enters this biliary tree, right? Conjugated bilirubin enters this biliary tree, right? Conjugated bilirubin, right? Okay. And it will travel all this way, right? All this way down. Some of it obviously will be stored here. Some of it will be stored in the gallbladder, right? We'll talk about that in a little bit later. The rest, right, will come here, right? We have the common hepatic duct, right? Common bile duct, all of that. And finally, guys, it will enter through the structure called the ampulla of Vater, right, to the second part of the duodenum. It will enter the second part of the duodenum, right? Comes out here. So what do we have now? Into the second part of the duodenum, we have conjugated bilirubin. Conjugated bilirubin, right? Okay. Everyone clear up to this point? Give me a thumbs up. Let me see your faces, Right, excellent. right? Okay. Now, what happens to this conjugated bilirubin in the GIT? Something special happens. Something special happens. Look at this, guys. Throughout our digestive tract, you know we have intestinal microbiomes, right? We have these bacterial species, various bacterial species lining our GIT, right? With the help of some of these bacteria, guys, with the help of some of these organisms, right? The conjugated bilirubin is converted. It is converted, right, to this. It is converted to this reddish color one. You can write it down. This is what we call, guys, urobilinogen. Urobilinogen, right? With the help of gut mucosal bacteria, conjugated bilirubin, right, is converted to urobilinogen, right? Urobilinogen, right? Okay. Let me extend this. Right? Urobilinogen. Now what are we left with? Urobilinogen, right? Okay. Look at this, guys. This urobilinogen, now the urobilinogen has two fates, guys. Look at this, two fates. I will draw one fate to this side and the other fate to this side, right? We'll first look at one. A majority, we'll put it this side, majority of the urobilinogen, what will happen to the majority of the urobilinogen, guys? It will be converted, it will be oxidized rather, to what we call urobilin. Urobilin, right? You can just put the letter U here. Urobilin, right? Urobilin, right? And this urobilin is, guys, this one is easily taken up by our kidneys, right? It is taken up by the kidney, by the glomeruli, right? Okay. And it will leave through our urine, right? Some of it will enter the urine. Urobilin. Trace amounts of urobilin is present in the urine, guys, under normal circumstances, right? Urobilin, right? Now, what do I want you all to know? Okay, we'll come to that later. Let's talk about the other one also and finish it off. Another one that it is converted to is, guys, stercobilin. Stercobilin. Sterco first bilinogen, stercobilinogen, and that will be oxidized to stercobilin. Stercobilin, right? Stercobilin. Now, stercobilin is the guy that gives the color to our stool. Color to our stool, right? Color to our stool. Now, here is one very important discrimination and one very important point I want you all to understand, right? Listen, stercobilin gives the color to our stool. Stercobilin is a very strong pigment, So if our normal stool color is something like this, okay, I'm drawing some poopies, look at this, right? Now, this is the normal color of our stool. If our stercobilin is even a little bit high, guys, the stool will change its color to something like this, much darker. It's not black tar, don't confuse with black. It's a much darker brown. It's a much darker brownish color, right? This is what happens when stercobilin is increased even a little bit. On the other hand, the important thing I want you all to know about urobilin is not such a strong contributor to the color of urine. Stercobilin is a very strong contributor to the color of feces. right? Urobilin, not a very strong contributor to the color of urine. So even if urobilin is increased, right? Even if urobilin is increased, will the color of the urine change a lot? Not really, right? So what is the important clinical aspect there? The patient will tell you, my stool color is changed, but I didn't notice any difference in my urine color. That's what they will tell you, right? They won't notice the urine. It will be very mildly a little bit darker, but that's it. Because why? Urobilin is not a very strong contributor to the color of urine. Now, so when I'm saying that, if I'm saying urobilin is not the major contributor to the color of urine, who is the major contributor to the color of urine? Who is the major contributor? Huh? What do you all think? A major contributor to the color of urine. Oh, bilirubin. Bilirubin. Keep this written down, right? We'll come to it later, right? Okay. Bilirubin. Urobilin is not a very strong contributor to the color of urine. Okay. Stercobilin, yes, stercobilin contributes to the color of feces. Okay. Right. Then again, guys, one more thing, this minority. We didn't talk about this minority side, no? Minority, what happens to this minority, right? Nothing major, guys. You all know we have a special venous system coming from our digestive tract that takes up one large vein and brings it all to the liver. What is this? What is this? These are hepatic portal vein, right? Hepatic portal vein. So some of this urobilinogen, a minor portion, right? A minor portion, this is not a very important high yield point, but just for you all to know, some of the urobilinogen will enter this hepatic portal system, right? Okay, and it will come into the circulation, right? I don't want to ruin this diagram. Maybe you all also can draw it some other way. I'll just draw it across, coming into the circulation, right? And then from there, they will be excreted, again coming into the kidney as urobilin, or going back into the digestive tract, right, through the liver, right? They can go back into the digestive tract and go as stercobilin, right? It's not a very important point, just to know, just for you all to know what happens to the remaining amount, right? So now what did we produce up to now? We basically took our RBC, broke it down into everything, right? And got rid of what is unnecessary, right? In the forms of urobilin in urine and stercobilin in feces. Okay, is everyone clear up to this? Right? Now this is your basic physio, right? This is our basic physio. Now with that understanding, guys, we can go to the pathophysiology of the hemolysis. Hemolysis, right? Clear? Let me see some faces. Right. Okay. So take a new page. Let's go to the pathophysiology of hemolytic anemias, right? Pathophys, right? Okay. Look at this, guys. Now, what is the definition of hemolytic anemia? Right? We are starting the clinical manifestation. We'll talk about that. But basically, this is a premature breakdown of RBC. Basically, what we are talking about, guys, is breakdown less than 120 days. So lifespan of a normal RBC is 120 days. When the RBC breaks down before that 120 days, it's called hemolysis, right? Here, guys, when there is premature breakdown, what happens? What happens? So, some basic things. First thing, hemoglobin, our body's hemoglobin starts dropping, right? Later we'll talk about the compensations and all of that, right? When hemoglobin drops, what happens, guys? Oxygen transport, right? Oxygen transport is affected. Oxygen transport drops, right? Transport drops. Especially when this hypoxic state reaches the kidney, what is produced in the kidney in response to this? What is produced?
EPO.
EPO, erythropoietin. erythropoietin production increases, right? Erythropoietin production increases. So we will start our pathophysiology from here, right? Right. Now, if we look at the kidney, guys, if we look at the, if we zoom in a little bit and look at our kidney, right? Where is this erythropoiesis be? Now, if you all remember the structure of the glomeruli, right? Something like that, right? Loop of Henle, distal convoluted tubule, and collecting duct, right? Something like this, no? Right? Look at this. If you all remember, guys, throughout this glomerular structure, we had the afferent and the efferent arteriole, and we had what we call these peritubular capillaries wrapping around these glomerular structures. We are not talking about the vasa recta here. Huh? That one is for another day, right? If you all remember, we had this peritubular capillaries, right? Peritubular capillaries. Now, EPO production, guys, it happens in these peritubular capillary endothelial cells. Peritubular capillary endothelial cells. This is where erythropoietin production starts, right? So this erythropoietin is a hormone. Huh? So what happens once this is produced, it will enter the blood. EPO will enter the blood, right? EPO, right? Enters the blood. Okay, erythropoietin, right? Erythropoietin, right? Then where does EPO have to go, guys, to stimulate? Where does EPO have to go to stimulate erythropoiesis? To the bone marrow. Excellent. Bone marrow. Specifically, guys, specifically in the bone marrow, these pro-erythroblasts, right? Specifically these cells, the first few cells, right? Early normoblasts, sometimes pro-erythroblasts and erythroblasts, especially pro-erythroblasts and erythroblasts, they have the receptors for erythropoietin. So what happens? EPO nicely comes and binds here, right? Now, does anyone know? So after EPO comes and binds, what is happening? How is erythropoiesis being stimulated? What is going on here? Any idea? What is happening? What do you all think? Try to come up with a hypothesis. What is EPO coming and doing here? Any guesses? No? Shashank, any hypothesis? Anything? No? Look at this. Yeah. Go on. Tell me.
That's okay.
Okay. Right. Okay. Look at this. Right. What happens is, guys, this EPO is something very simple, but the mechanism is very complex, right? We are not going to go into the depths. What EPO does is that this EPO is an anti-apoptotic enzyme, hormone. We can call it a hormone, anti-apoptotic hormone, right? Anti-apoptotic hormone, right? So what does it do, guys? It increases the lifespan of RBC progenitors, right? Red blood cell progenitor lifespan is going to be increased, right? Okay, RBC progenitor lifespan increases. Now, why did I say it is a very complex mechanism? Programmed cell death, right? Remember, we talked a little bit about this in our lung cancer classes, right? We talked about some specific proteins, some CD proteins. This is a very complex mechanism. We don't need to talk about that, right? End of the day, what is happening? RBC progenitor lifespan increases. What happens with, what is the obvious thing that happens now? So the progenitors live for longer, so they can do multiple cell divisions. So what is happening? Erythropoiesis increases, right? Erythropoiesis increases. Okay, right? Now, this property that EPO brings to the bone marrow, right, helps us in a key way when we are doing our diagnostic studies. What do we see, guys? Now, when the RBC progenitor lifespan is increased, they live for longer, right? So if you look at the bone marrow, what will you see? You will see a lot of erythroid cells, right? The RBC progenitors will be, because they are living longer now. They're living longer, right? What do you see, guys? If you take a biopsy, right, what will you see, right? Large accumulation of cells. This is what we call bone marrow hyperplasia. Hyperplasia specifically, guys, we call this erythroid hyperplasia, right? Erythroid hyperplasia, right? Right. So if you look at the erythroid to the other series, the ratio, if you look at the ratio, right, erythroid will be much higher. Erythroid will be much higher. Why? Erythropoietin is coming and acting there, right? Right. Okay. So what is this, guys? What is EPO doing? Now, how did we start off? There was a reduction. There was a premature breakdown, less than 120 days. HB dropped, right? O2 dropped, hypoxic state, kidney detected that, increased EPO. Now what is happening? Erythroid hyperplasia. What is this? This is a compensation mechanism, right? By our body, right? Is a compensation mechanism to replace the lost RBCs, right? Replace the lost RBCs, right? In fact, guys, you all can put this in a note or in a star. In fact, right, with the help of erythropoietin, our bone marrows are capable of increasing RBC production up to 6 to 8 times. 6 to 8 times of the normal if it is required. If it is required. Right? So depending how severely our RBCs are being broken down, our bone marrow is able to compensate with the help of erythropoietin up to 6 to 8 times, right? Okay, the production. Now, this just note down, put a star here. This 6 to 8 times is in a normal person. What do I mean by normal person, guys? No iron deficiency anemia, no folic acid deficiency, no vitamin B12 deficiency, right? Nothing, no condition like that. In a completely normal, healthy individual, up to 6 to 8 times, yes, the bone marrow can compensate. Right? Right. So look at this. Let's say now, what is our normal RBC lifespan? 120 days. Right? Now, due to some condition, right? We'll talk about the examples later. Due to some condition, now I'm telling you, my RBCs are living only 20 days. Only 20 days. Right? So the lifespan has reduced by how much? 120 over 20. Lifespan has reduced by 6 times, right? 6 times. Lifespan reduced by 6 times, right? Now, what did we say about the bone marrow's capability as long as the person is having healthy hematopoiesis, erythropoiesis? What is the bone marrow able to do? Up to 6 to 8 times can compensate. No problem, right? So bone marrow in this condition, what do you think? Will the patient show, if my RBCs are living only 20 days, will I show manifestations of anemia? Will I show manifestations of anemia? Not really,
No.
right? Okay, so this is what we call, guys. So no manifestations of anemia, right? Of anemia, right? Because my bone marrow can compensate. This is called, guys, compensated hemolytic disease. Why do we call this? Because this is still a disease, guys. Due to some cause, our RBCs are being broken down by the 20-day period instead of living 120 days. So it's still a disease, it's still a pathology. But we do not call this anemia because there are no manifestations. This is why we call this compensated hemolytic disease, right? Okay. Now we'll take another example. Look at this. Normally, RBCs live for 120 days. Now I'm telling you all, now due to some reason, right? My RBC lifespan is only 12 days. 12 days. How much has the lifespan reduced by? How much is the destruction now?
110.
By 120 over 12, right? 10 times, right? 10 times, huh? See, this math is an issue for me. By 10 times, right? By 10 times, now the RBC lifespan has been reduced. Now, what is the maximum rate that our bone marrow can compensate? 6 to 8. Bone marrow compensation maximum is 6 to 8 times. Now, what do you all think? Now, what do you all think about this patient? What will happen to this patient? Huh? Tell me this, will he immediately fall ill? Will he immediately fall ill? Huh? What do you all think?
Yeah. So there will be like manifestations after the remaining RBCs have been.
Yeah. Okay. Yes, you're correct. You're correct. Right? You're correct. Don't overthink about the RBC numbers and everything. Just what I want you all to know here, since the bone marrow still has at least 6 to 8 times compensation ability, there will be a progressive, what we call a progressive loss reduction in hemoglobin. So you don't see a sudden overnight drop in hemoglobin, right? Right? You will have a progressive reduction in hemoglobin in these patients. And when there is a progressive loss in hemoglobin, guys, we will start little by little manifesting anemia, right? Manifesting anemia. The patient will start manifesting clinical features of anemia. This is when we call it hemolytic anemia, right? Hemolytic anemia, right? Because the body tried to compensate, but the rate of destruction is much higher, 10 times, right? That the bone marrow cannot keep up with the compensation. Therefore, little by little, the patient will start manifesting anemia. Okay. Everyone clear up to this point? Right? Now very easy, guys. If you all have these basics, very easy. There are some little bit more when we come to the autoimmune parts. Don't worry, we'll go through those. Right? So these basics, is it clear? Give me a thumbs up. Let me see your faces. Right? All good? Right. Awesome. Awesome. You guys turn on your cameras. Right? Okay. Now we'll come to the clinic. Now we'll be doctors. We'll be doctors. Let's say we get a patient coming in with some manifestations of anemia. Don't worry, we'll talk about these manifestations of the hemolytic anemia later, okay, in the diagnostics part. Now I'm telling you all, okay, let's say you're the resident, right? And your senior doctor is saying, okay, go to bed number 23. That patient has been diagnosed of hemolytic anemia, right? Go and do your examinations, go do your ward, do whatever, right? Get the history from the patient, do whatever, right? What are we going to do when we have a patient, right? The first thing we want to confirm is, guys, write this down. The first thing you all as medical professionals, what you all should ask yourself is, first confirm, is there hemolysis or not, right? Is there hemolysis? Is the first thing. Is the first thing, right? Is there hemolysis? How do we confirm that, right? Okay, let's see how we can confirm that. What can we do? First thing, guys, in their blood, right? In their blood, what did we say? For now, what did we talk about? We said later we'll talk about the intravascular, extravascular, all of that, right? Don't worry about that. From the physiology, what we discussed, what did we see, guys? From the spleen, in the spleen, when there was RBC breakdown, what was thrown into the blood? From the spleen, what came into the blood during hemolysis? What came in?
Bilirubin.
What bilirubin? What bilirubin?
Unconjugated.
Unconjugated bilirubin came in, right? So first thing what you can look for is, write this down, unconjugated hyperplasia Bilirubinemia. Bilirubinemia. The emia means what? In the blood, right? Okay. Unconjugated hyperbilirubinemia, right? Now, when unconjugated bilirubin is high in the blood, in the serum, how does it manifest? How does it manifest? In the patient?
Jaundice.
Yes, a discoloration of the skin, a yellowish discoloration of the skin that we call jaundice. Now, here is a very important point I want you all to understand, right? This jaundice that comes with unconjugated hyperbilirubinemia is almost always mild. It is a mild jaundice, guys, mild discoloration of the skin. Why? Can someone think and tell me why? Why? Why?
Because conjugated bilirubin is the major thing which gives the color.
Right, we'll talk about conjugated in a little bit. Fine. But why do you think unconjugated cannot give a nice color? What is happening? What is our body capable of doing? Anything? Any guesses? Any hypothesis? Now, unconjugated bilirubin, when it came to the serum, what happened when it came to the serum?
Albumin started binding to it. So
albumin started binding to it. Now, can you think of something? I'm telling you all, this unconjugated bilirubin is not very capable of giving a very strong yellow color. Why?
the albumin doesn't let it.
Okay. Right. We'll look at it this way, right? Y'all are good. Y'all are good. Y'all are thinking something, right? We'll look at it this way. What I want you all to realize is, guys, as long as the person's liver is functioning well, right? This unconjugated hyperbilirubinemia will not give a strong jaundice. Why? The liver, the moment the liver sees a lot of unconjugated bilirubin coming into the blood, what will the liver do? It will increase albumin production to go and capture as much as possible and bring them to the liver, right? So they don't easily go far away and deposit under the skin, right? Giving the color, giving the strong color, right? So what is happening? Just note this, guys. As long as liver function is normal, this is very important. So if someone is having hepatitis or something, different story, right? Or cirrhosis, different story. As long as the liver is functioning normal, right? Liver function is normal, right? What will happen? Liver will increase its function. Liver will further increase its function to compensate and bring as much bilirubin as possible into the liver, right? Okay. Did everyone understand that point? All good? Right? Okay. Right? Then now we'll say, so what is happening? A lot of unconjugated bilirubin. Unconjugated bilirubin will be brought to where? Will be brought to the liver. Right? A lot of unconjugated bilirubin will be brought to the liver. This is why the jaundice is mild, right? Now you all know the process. What is happening in liver? In the liver, what is happening? Unconjugated converted to conjugated, right? The UDP glucuronide transferase. It will be converted to the conjugated, and the conjugated will enter the biliary tree. From the biliary tree, it will enter the digestive system. In the digestive system, what did we say happens, guys? With the help of bacteria, it is going to be converted to urobilinogen. Now, if we have a lot of unconjugated bilirubin, what do you think happens to the urobilinogen? What happens to urobilinogen in the case of hemolysis? Increases. Urobilinogen increases, right? Understandable, no? Why? A lot of is coming into the digestive tract now, right? Due to the hemolysis, right? Then, if urobilinogen increases, what happens? Right? We know, we'll talk about remember the majority pathway. What is one thing? Stercobilinogen. What happens to stercobilinogen? What happens to stercobilinogen? Increases. If stercobilinogen increases, what happens to stercobilin? Stercobilin increases. If stercobilin increases even a little, what happens? What is the complaint? dark stool. Patient will complain of dark stool, right? Dark stool, right? Then what's the other thing we said?
Europe.
Directly from there, the urobilinogen will be, some of it will be oxidized to urobilin, and that will enter the kidney, right? Kidney. Now, urobilin in the kidney, right? Urobilin can come into the kidney. We'll put the kidney here, guys. Let me put kidney in big letters, huh? Kidney, right? Okay. Urobilin, when it comes into the kidney, does it affect the color of the urine very much or noticeably?
Not much.
No, not much, not much. So will the patient usually complain to you about change in the urine color? No, right? They will say, no, I didn't notice anything like that. So you can just put, right, mildly affects urine color, right? Right. So the bilirubin, the unconjugated bilirubin here, guys, unconjugated bilirubin here, what is immediately happening soon after it enters the blood? It is going to be bound with albumin. This is what we talked about. It will be bound like this to albumin, right? So what do you think? Can unconjugated bilirubin enter the kidney? Bilirubin is the one that we said gives the major color to the urine. Can it easily pass through the urine and give the color to the urine? Just because it's high. Now we know unconjugated bilirubin is going to be very high in hemolysis, right? But can it come to the urine now? Why not?
Because it's bound with albumin.
Because it's bound with
Protein.
albumin. We know unless there is a nephrotic or a nephritic syndrome, something like that, albumin is usually not allowed to leak. There is a very minute amount of protein, trace amounts or no, right? So what is happening? This urine color will not be dark. Why? The bilirubin cannot enter. It is bound with albumin, right? For this reason, guys, this picture, this clinical picture, right? This is called acholuric jaundice. Write this down. I will explain what this is. Acholuric jaundice, right? This call word, guys, this is we reference to bile and its components, right? You all know cholecystitis, right? All the gallbladder, all the structure, the call word, right? Now, what is this? Acholuric. What are we saying here, guys? Patient has jaundice, right? Okay. But does he have bilirubin in the urine? No bilirubin in the urine. No bilirubin in urine. So therefore, urine is the normal color. What does he have in the urine? Only urobilin. You can write down only urobilin in the urine. But that urobilin does not strongly stain the color, right? So minimal change in the color, minimal. So this is what we call acholuric jaundice, right? Now, just to make sure you all don't get confused, right? Right? Look at this. If I have, right, some sort of, let me say, okay, this is my liver, right? And this is my biliary tree coming down like that. I will draw this here. Something like this, right? And this is joining the second part of the duodenum. This is just an extra. This is not our chapter today. This is just an extra point to make sure you all don't confuse the two, right? Now I'm telling you all this. In some cases, some patients, I will say this patient has some sort of an obstruction here. Let's say a cancer, malignancy, right? Cancer or malignancy here, right? Now tell me this, guys. Now, what whatever substances that are coming from here cannot travel further down, right? Therefore, they reflux into the circulation. These substances, they will reflux into the circulation. Now in this patient, what is coming into the circulation? Tell me. Many things are coming. That's the first thing I want to know. First thing, a lot of conjugated bilirubin comes into the circulation when there is an obstruction in the biliary tree, right? When there is some sort of an obstruction in the biliary tree, conjugated bilirubin comes into the circulation, right? Conjugated bilirubin, right? This one is not bound with albumin like the unconjugated one, right? Unconjugated one, what did we say? Soon after it comes into circulation, immediately bound to albumin and then brought to the liver. Conjugated, different story, right? It enters the circulation, right? What happens, guys? First thing, it can go to various parts of the body and deposit, right? This is going to give a strong jaundiced appearance, conjugated bilirubin. And what is the other thing it can happen? It can go to the kidney. It can go to the kidney and enter our urine stream. Now what is happening? Conjugated bilirubin in the urine. What do you think?
Dark urine.
What did we say? Bilirubin is the guy who gives the major. Guys, can you all mute yourselves? I'm kidding. Right. There we go. Right. Okay. Look at this. So what is going to happen? The conjugated bilirubin comes to the kidney. From the kidney, it is going into the urine, and in the urine, it is going to give a very dark color. Right? Why? Bilirubin, we said, is the major contributor to urine color. So if bilirubin is even a little high, when it comes to the urine, if it reaches the urine, right? Dark urine, right? Right? Now look at this. At the same time, guys, now when there is an obstruction here, will there be enough conjugated bilirubin coming into the digestive system? What do you all think? No, right? So this conjugated bilirubin coming into the digestive system will be less. If conjugated bilirubin in the digestive system is less, what is less? What is the next one that is less?
So, urobilinogen will be less.
Urobilinogen will be less. Therefore, what do you think happens to stercobilin? What happens to stercobilin?
Also reduced.
Stercobilin also less. Therefore, what will happen to the color of the stool? Stool color, what will happen? Pale stool. Now, what do we have up to now? We have dark urine and we have pale stool. Dark urine, pale stool, right? Two things. Third thing, guys, when there is an obstruction here, what did we say? Conjugated bilirubin can reflux into the blood. Like that, certain other things also can easily reflux. One other thing that refluxes like this, guys, are bile acids. They also reflux into the blood. Bile acids, right? Bile acids, guys, they are highly irritant. So they come to your skin, especially to your subcutaneous tissue, and they cause skin irritation. This one in medical terms, what do we call this? Pruritus, itching, right? What is this? What triad is this? What is this triad? I mean, there is no name for the triad. I'm just asking, what is the disease? What is the diagnosis? Write this down in red color. Dark urine plus pale stools plus pruritus. Obstructive jaundice until proven otherwise. Okay? Obstructive jaundice until proven otherwise. Dark urine, pale stools, pruritus. Okay? Obstructive jaundice until proven otherwise. Now, why did I teach this here? This is not our chapter today, just to make sure you all don't confuse it with the others, right? and to register in your minds, right, about this bilirubin, which gives the primary color to urine, right? Okay. Right. Everyone clear about this? So this urine has bilirubin, right? This is what is another name in some old books, especially Urine Jaundice. You just remove the A, right? It has bilirubin in the urine. It has bilirubin in the urine. Urine Jaundice, right? Okay, clear. Right. So we'll come back to hemolysis, guys. This was a little bit out of our chapter. We'll come back to hemolysis. So we were trying to find out, is there hemolysis or not? So we were looking at evidences of hemolysis. Right now we talked about three things. What was the first thing? Jaundice. Jaundice, usually most of the cases it is mild. Most of the cases is mild. Later when we come to intravascular hemolysis specifically, we will talk about some severe forms. Most of the cases mild, mostly mild. Okay. Then what we said, in their blood also and in the digestive tract, what will happen? Urobilinogen will increase. They will have dark stools. Right? Urine color, not so much affected. So we don't write it here, right? It's not very relevant. Almost none of the patients will complain of that, right? Then guys, so these three we have discussed. Then the fourth one, you are going to put fourth one. Another thing that happens with hemolysis that we can observe is when there is RBC destruction, guys, right? There is this substance released from the RBC itself, lactate dehydrogenase, LDH, right? LDH gets from the LDH, which was supposed to be in the RBC, gets out when they're broken down and comes into the circulation. When they come into the circulation, guys, serum LDH increases, right? This we can do in the blood count, in the blood panel, right? Serum LDH can be measured, right? This is another thing we can look for. Another evidence for hemolysis, right? Right. The fifth one, guys, look at this. Now, first write this down. Fifth one, we have something called heptoglobins. Heptoglobins. During hemolysis, heptoglobins will reduce, right? We'll see what these heptoglobins are, why are they reducing, what is going on, right? These heptoglobins, guys, these are some structures produced by our liver. They are globins, they're proteins produced by the liver, right? So they look something like this. Heptoglobins. What is the function of heptoglobin, guys? They bind with free hemoglobin. They bind with free hemoglobin that is released during hemolysis. Right? Now I'm going to tell you all there are two forms of hemolysis, right? Look at this, guys. Hemolysis, one is called extravascular. What do we mean by extravascular? Not occurring inside blood vessels. Another form of hemolysis is what we call intravascular. They occur in the vessels. The RBC breakdown happens in the blood vessels itself. So extravascular one is what we've been discussing all this time. Where does extravascular hemolysis mainly occur?
Spleen.
Mainly in the spleen. Then there can be some other reticular endothelial systems as well, guys. A little bit can happen in the liver, some in some lymph nodes, but these are not important. Major location for extravascular hemolysis is the spleen. right? Intravascular hemolysis happens in the blood vessels. Now tell me this. When RBCs are broken down, we already discussed the extravascular pathways in a little bit of depth actually. There, what did we see? When the RBC broke down in the spleen, what happened to the HB? What happened to the HB within the spleen? What happened to it? It was broken down into what? Heme and globin. We were able to separate the heme and the globin. The globin part, it will be disintegrated into amino acids. The heme component, right? We made it into biliverdin and the iron. We took out the iron. We recycled iron. All of that happened nicely inside the spleen, right? So when hemolysis occurred inside the spleen, no issue, right? Guys, can you all mute yourselves? Someone is. Does anyone have a question? No, right? Okay, right? So what is happening? When extravascular hemolysis happens in the spleen, guys, no problem, right? Just note, if the rates of extravascular hemolysis are very high, very high, a very little amount, you can put a you can put two very, very little amount of free HB, free hemoglobin can leak out into circulation. But this also, guys, this also happens only if the rates of hemolysis are very high. Usually it doesn't come into circulation, free hemoglobin, right? When there is extravascular hemolysis. What do you think of intravascular hemolysis? What happens to hemoglobin? What do you think?
All hemoglobin in the circulation.
Hemoglobin straight away dumped, right? HB dumped into circulation. Now look at this. Still, not a very. It's a bad situation, but still our body has a mechanism. What is the mechanism? Heptoglobins. Whenever there is free hemoglobin in the circulation, guys, right? Whenever there is free hemoglobin in the circulation, heptoglobins will come, immediately bind with them. Immediately, heptoglobins will bind with our free hemoglobin, right? Our hemoglobin, it was this tetrameric structure. We are not going to draw it now in fully, and it had the globin chain, something like this, right? What happens? Immediately, heptoglobins will come and bind with the free hemoglobin. Once this complex is formed, guys, the heptoglobin hemoglobin complex, once it is formed, this one is highly attractive to macrophages, right? Highly attractive to macrophages. So what will happen, right? All the macrophages will come, start eating them, engulfing them, right? And removing the free hemoglobin within our system, right? So these heptoglobins are very helpful, right? Heptoglobins are very helpful for us during this hemolysis. At the same time, heptoglobins are very helpful for us in diagnostics. What do you all think? How?
To differentiate from intra and extravascular.
Differentiate from intra and extravascular, heptoglobins can help. How? What will happen to heptoglobins in extravascular versus what will happen to heptoglobins in intravascular? What do you all think? Yeah.
Not only in extravascular. And
Sorry, I did not hear you. It broke, the voice broke.
Normal in extravascular and low in intravascular.
Excellent. In extravascular hemoglobins, hemolysis, guys, heptoglobins will be very mildly, you can draw it in a dotted line, mildly reduced sometimes, or most of the time it is normal. Heptoglobins are normal, right? It can be mildly reduced depending if the extravascular hemolysis is very severe. Yes, some heptoglobins will be occupied by the hemoglobin, so heptoglobin concentration drops. What do you think about intravascular hemolysis, guys? Heptoglobins. Heptoglobins reduced severely, or sometimes they disappear. You don't even see them because all of them are saturated with hemoglobin. All of them have been bound with hemoglobin, right? Severely reduced or disappears. Right? Everyone understood that? Right? So this is about heptoglobin. So we have 5 evidences now, right, to see if hemolysis is happening or not. First thing is the jaundice. This one, obviously, it's not a very specific one, guys. Jaundice can happen due to multiple number of causes, but yes, it is an indication of hemolysis, right? Serum urobilinogen will increase if you check their urine, right? Urobilin will be there, right? Stools will be dark. This one, the patient will also complain to you, right? If you look at their blood, again, serum LDH will be high and heptoglobins will be less. And this one can be less or normal in extravascular, whereas it will be severely reduced or disappeared in intravascular. Everyone good up to this? All good? Right? Give me a thumbs up. Right? Okay. Right, let's move on. Now, so that was the first question that we answered. The first question was, right? Right. The first question was, is there hemolysis or not? Is there hemolysis or not? Right. Now we come to the second question when we have a patient, right? Question number 2. What do we need to know now? Is the bone marrow compensating or not? Is the bone marrow compensating or not? Right? Okay. Is the bone marrow compensating or not? Right? Now, what do we know, guys? When there is hemolysis, right, due to the erythropoietin, our bone marrow activity increases. Right? So when the bone marrow erythropoiesis increases, what is one of the first things that happens? Our fresh red blood cells or brand new red blood cells increase. Fresh RPCs increase. Right? Fresh RPCs increase. What are these fresh RPCs? They're still immature, guys. They're still a little bit immature, but they're coming to circulation. We call this reticulocytes. Right? Reticulocytes, are they larger or smaller than mature RBCs?
Large.
They are larger, right? If you all remember that cascade, little by little, the cell size gets smaller. So the mature RBC is the last one. So reticulocyte is one before the last. So it's a little bit larger. Right? You all can write that down a little bit. So in the blood smear, you can see a little bit larger than mature RBCs, right? And what is another one, guys? They still have some RNA and ribosomes remaining, right? Still not removed from their system. Some RNAs and ribosomes. Therefore, when you stain them and when you look under a microscope, guys, they don't look nice pink under the microscope. They will look a little red bluish, right? Reticulocytes are a little bit red bluish on staining, right? They don't look like a nice mature RBC, which is nicely pink with a central pallor and all of that. No, these guys look a little bit red blue, right? Then now if reticulocytes increase, guys, we have what we call the reticulocyte count. In a normal person, guys, the red count, if you take their blood sample, only 1 to 2% max, right? 1 to 2% will be reticulocytes. The rest will be mature RBCs, nice mature RBCs, right? But what happens when reticulocytes increase? Obviously, the red count increases. So this can go sometimes 6, 7, 8, 9, 10% sometimes, right? So this percentage increases, right? Right? So this reticulocyte increase, what is it? It is a sign that our bone marrow is trying to compensate. So it's a good sign. right? Now, here's what I want you all to know, guys. For your exams, if they ask for the hemolytic anemias, what is the best approach to diagnose? If reticulocyte count is there in the answer, go with that. This is the best test, right? The best lab study, right? One of the best lab studies. Obviously, we have other tests that we can do, but for your exam purposes, this is the best test for diagnosing hemolytic anemias in the lab, right? Reticulocyte increase. This is sort of like the golden standard, although it is not officially the gold standard. It doesn't say that in any book, but that is what we take, right? Right. Second one. Here's an important thing. What do you think will happen to the mean corpuscular volume, MCV? You all know, guys, the mean corpuscular volume is usually about 80 to 100 femtoliters. 80 to 100 femtoliters. This is how we decide between microcytosis or macrocytosis or the normosity, right? 80 to 100 is the normal size. What will happen to MCV in the case of hemolysis? What do you all think?
Increase
Yeah, why?
because reticulocytes are large.
Excellent. Very simple. Reticulocytes are large, so it is usually greater than 100. Usually, guys, somewhere between 100 to 110, right? Usually, this is for your clinical knowledge. When you all meet patients in the clinic, right? Usually, the MCV is about 100 to 110. It's not very severely increased. We'll see a condition. In today's class itself, we will see there are some other conditions where you see the MCV going 150, 180, right? Very high, very high. We'll talk about that in a little bit. But for the most case, hemolysis, just because of the increased reticulocytes, right? The MCV is seen a little bit higher, 105, 110, that amount, okay? Femtoliters, right? So there is a slight macrocytosis, basically due to the reticulocytes, right? Then look at this, guys. The third one, if you look at the blood film, right? The blood film. What did we say, guys? So obviously, this patient, they will have some mature RBCs. Some mature RBCs will be there. So the mature RBCs, we know they'll appear nicely pink. At the same time, they have an increased red count. So reticulocytes are high. So they are going to appear as a bluish red, right? Red blue, bluish red. So you will see some bluish red cells. You will see some pink cells, right? This variety of colors, guys. Variety of colors, right? This is what we call polychromasia, right? Polychromasia, right? Polychromasia in the blood film, right? A normal person, what will we see? We will see almost the entire blood film is pink, right? Because only 1 to 2% reticulocytes. In 100 RBCs, only 1 or 2 are reticulocytes, right? But in these cases, 7, 8, 9, 10%, sometimes 20% reticulocytes, right? Therefore, what is going to happen? You can see that different colors within the same slide, right? Very prominent. So polychromasia, right? So all of these things, guys, reticulocytosis, polychromasia, and increased MCV, mildly increased MCV, these are signs that the bone marrow activity is good and the bone marrow is compensating. Okay, if these are not there and the patient has hemolytic anemia, what is the issue? They have hemolytic anemia due to some cause and their bone marrow is also not trying to compensate. What will happen? Very rapid progression of anemia. We'll talk about those in some upcoming lectures, right? And the bone marrow is dysfunctional. For now, so we've talked about that, right? Now we know that the bone marrow is compensated. The third question, guys, write this down. Question number 3. Is it intravascular or extravascular hemolysis? Now for this, we've already discussed one. I talked about this. What is the first one? If it is, let's put it there, if it is extravascular, tell me this now, heptoglobins will be what? Increased, decreased, moderately increased, mildly decreased, what? Normal, what? Tell. Extravascular hemolysis happening in the spleen. What happens to heptoglobins?
Normal.
Yes, mildly decrease or normal. Mildly decrease or normal, right? Okay. Mildly decrease or normal. Then look at this, guys. In extravascular hemolysis, where is the major site? Spleen. Therefore, what do we know? The spleen is overfunctioning, right? The splenic macrophages are hyperfunctioning, guys, right? Because they are killing a lot of RBCs, right? They're very busy, right? This gives rise to something we called, guys, workload hyperplasia, right? Just because of the increased workloads, the numbers of macrophages increase, right? This gives rise to what? When there is a lot of cells in the spleen, what happens? How does it manifest? Splenomegaly, right? Splenomegaly, right? Clear? Now, tell me this. What do you think in extravascular hemolysis? I'm going to tell you all there is a condition where hemoglobin can come into the urine. This is what we call hemoglobinuria. Hemoglobin coming into the urine. Hemoglobinuria, right? What do you think? In extravascular hemolysis, do we get a severe hemoglobinuria?
No.
No. Everyone understand that point, right? So you write it down, huh? No severe hemoglobinuria. So therefore, now another thing I want you all to know, guys, when hemoglobin comes into the urine, the patient will complain it how? Huh? Very dark urine. They say my urine is like Coca-Cola, right? Cola colored urine. For hemoglobinuria, we say cola colored urine. So in the case of extravascular hemolysis, the patient will not complain of such a thing, right? No, they won't complain of a cola colored urine. So we will leave it there. No severe hemoglobinuria. Now we will come to if the hemolysis is intravascular. If IV, tell me, heptoglobins, what happens?
Reduces.
Severely reduced or absent, right? Severely reduced or absent, right? Heptoglobins. Okay. Now, here there is an important mechanism. Heptoglobins, right? Now let's say heptoglobins are absent. What do I mean by this saying heptoglobins are absent? What do we mean by this? All of the heptoglobins have been occupied by hemoglobin, correct? So heptoglobins are 100% saturated with hemoglobin, right? Everyone understand this? Heptoglobins are 100% saturated with hemoglobins, right? Look at this, guys. Then, as hemolysis continues, now will there be heptoglobins to bind to them when there is 100% saturation? No heptoglobins to bind. So now what is going to happen? There will be free hemoglobin in the blood, coming into the blood as the hemolysis continues, but we don't have sufficient heptoglobins. So free hemoglobin starts accumulating in the blood, right? The first thing I want you all to know, when free hemoglobin is in the blood, what is it called? What is the medical word? What is it?
Hemoglobinemia.
Excellent, right? Nothing to think too much. Hemoglobinemia. Hemoglobinemia, you all can write it down in brackets. Hemoglobinemia. Now, this free HB in blood, guys, there are two fates. Let's look at this. Let's look at what is going to happen, right? I can put two arrows like this, right? Number one, what happens to this Free hemoglobin. This free hemoglobin, guys, the iron is what? In the Fe2 plus form. The iron is in the Fe2 plus form. So this is easily oxidized by various enzymes. We don't need to talk about which exact on a molecular level what is happening. We don't need to know. Just note this Fe2 plus of the heme, right? Fe2 plus of the heme will be converted to the Fe3 plus, right? And hemoglobin with an Fe3 plus, right, which was basically oxidized, we call it methemoglobin. Methemoglobin starts increasing, right? Methemoglobin starts increasing. This is basically the hemoglobin with the Fe3 plus, right? So when methemoglobin starts increasing in the blood, what do you say? What is the medical term? Huh? What is it?
Methymoglobinemia.
Methymoglobinemia. Very easy, no? Very easy. Look at this, guys. This methymoglobinemia, guys, methemoglobin, if you take the patient's blood sample out, right? This blood looks like a chocolate color blood. Okay. This gives rise to a chocolate colored blood. Okay. Right? It's a very dark brownish color blood. This is basically due to the Fe3 plus ion, guys. Due to the Fe3 plus ion. Now, what I want you all to know, this methemoglobin, this compound, guys, this one is unstable. This is unstable. So it tends to dissociate, right? It dissociates in two things, right? Again, what does it dissociate? Hemoglobin, when it dissociated, when it was broken down, what did it dissociate to? Heme and globin. Heme and globin, right? Everyone agrees? Here, the same thing. Methemoglobin also dissociates into heme and globin, right? But this heme, since it is Fe3 plus, we call it periheme. Periheme, right? Periheme and globin. Methemoglobin dissociates into periheme and globin, right? The globin we are not going to talk about, right? It will come to the liver, it will go to the spleen, it will be broken down, right? We don't need to talk about that. This periheme, guys, FH, periheme. This one, right? Periheme, Fe3 plus heme, staying in the blood is not good, right? It can give rise to free radicals. It can go and react with various substances in our body. Therefore, our body, especially our liver, has another backup. See, our liver is a major savior, guys, right? Liver produces various things to get rid of these toxic substances, right? Okay. Okay. This is why you should not drink alcohol. Okay. Right. Don't message after class, asking about stuff, right? Look at this. Now, what happens? The liver produces another molecule, right? This is called, guys, pH, plasma hemopexin, right? Plasma hemopexin. Since this periheme is very dangerous to our body, plasma hemopexin comes and quickly binds with them and inactivates them, makes them non-reactive, right? So this is the end product will be FH, right? pH. This complex, periheme and plasma hemopexin, right? So if this happens, no problem, right? No toxin, no toxic effect, right? No issues. Now, tell me this. What happens if the hemolysis rate of hemolysis is very, very high? What will happen? What will happen? What will happen? Now, again, this is again coming to our liver. Who was the savior? Liver. Liver produced the plasma hemopexin. Because of that, okay, no issue. What happens if the rates are very high of hemolysis? What do you all think?
It will increase and there will be saturation of hemopexin.
Excellent. Plasma hemopexin can get fully saturated. right? Liver might not be able, at some point, liver will not be able to keep up producing with the producing more and more plasma hemopexin, right? At that point, plasma hemopexin will be 100% saturated. And in that case, guys, right, if pH is 100% saturated, the ferriheme, right, will go and bind with another substance in our blood. What is this? Albumin. Albumin, right? Ferriheme will bind with albumin, right? Okay. This gives rise to what we call, guys, you can write it down, metheme albumin. Metheme albumin, right? Metheme albumin, right? Metheme albumin, right? So these don't happen in a day, huh? Okay, these metheme albumin formation, this is after the compensation abilities fail, right? Okay, right. Now look at this metheme albumin. What will happen? This can be used for our diagnostic tests. We have a special test, guys, called Shum's test. Shum's test, right? Shum's test, right? This one, guys, as medical students, we don't need to know too much about, because this is up to our lab technicians, right? This is a spectroscopy, guys. Spectroscopy test, right? It's a spectroscopy test. Basically, right? Write this down. What do we do here? We draw the patient's blood. We take the blood out, right? And we separate the cellular components and the plasma. What we want is the plasma. We want the plasma. Why? Albumin is present where? In the plasma, right? So metheme albumin is also present in the plasma. So we take the blood out, we separate the plasma from it, and to the plasma, guys, right, we add ammonium sulfide. Ammonium sulfide, right? Okay, and we view it under the spectroscope. Spectroscope. We view it under the spectroscope, right? Here, guys, under the spectroscope, right, we'll get this band here, right? We have the wavelengths are here now, guys. Let's say 300 nanometers, right? 400 nanometers, somewhere around 550 nanometers to 600. Somewhere in this region, we will get a nice green color band in the spectroscope. This green band represents metheme albumin. Metheme albumin. Okay, metheme albumin. So this is a positive Shum's test. Positive Shum's test, right? This test, guys, no need to know in depth, right? You just need the name. If you remember the name, that's more than enough, right? Just know Shum's test detects metheme albumin. Metheme albumin produced in hemolysis. Hemolysis. Okay. Right? Clear? Right? Clear after this? All good? Okay. See some faces. Good. Dilshani, all good? Understood? Right, excellent. Right, look at this. So that was the first fate, right? We talked about, we divided this pre-HB into two fates. No, the first fate, that was the first fate. The second one, what happens again, right? Once the heptoglobin has reached 100% saturation, what happens with the free hemoglobin, right? Some of this free hemoglobin, guys, you all can draw this structure. We'll draw our glomerular structure that we love so much. Right, distal convoluted tubule, and the collecting duct. Right? Look at this. Some of this free hemoglobin, guys, this free hemoglobin, something like this, no? Something here, and then we have the globin chain. Some of this free hemoglobin, guys, can enter here, right? Can enter here, right? And here, if you all remember, in our nephrology, right? In our nephrology module, what did we say about these proximal convoluted tubule epithelial cells? Does anyone remember? What is one thing special about them? They are very greedy. Do you all remember? Whatever comes, they like to take, right? We talked about this, right? Same thing happens with iron as well, right? What happens is, guys, look at this. This free hemoglobin can come, right? Some of it will obviously, we'll first finish that off. Some of it will go through the urine, right? Come here and end up in hemoglobinuria. Hemoglobinuria, right? What is this? Cola colored urine, right? Keep that in mind. Okay. Right? Then, so that is one portion of it. The others, guys, they will be taken up into these proximal convoluted tubular epithelial cells, right? These fellows are very greedy, right? PCT cells, right? Look at this, guys. What happens here? In the PCT cell, right? They take up these dimeric forms of hemoglobin. Hemoglobin is usually a tetramer, right? It will be broken down and taken up into this dimeric form. Here, guys, once it is entering the PCT cell, proximal convoluted tubular epithelial cell, what will happen? It will be broken down and iron will be released. Iron will be released inside the cell. Iron will be released inside the cell. Now, what will happen? What will happen to the PCT cell? Think. What do you all think? Huh? Any idea?
Because it's toxic.
Right. Good. We have two pathways actually. What is going to happen? We have two things that is going to happen. One is the toxicity. Okay. One is the toxicity. Before toxic levels are reached, do you think anything else can happen here? What do you all think? Huh? What do you all think? Look at this, guys. Our PCT epithelial cells, their nucleus also can code for what? Apoferritin. They also can code for apoferritin, right? So what will happen? Apoferritin will come, right? Bind with the iron, forming ferritin, and if the levels are too much, they will further aggregate into hemosiderin. This same process will occur in the PCT cells as well. Then, right, what happens, guys? You all know, just like our gut mucosal cells, these cells also regenerate. So these PCT cells eventually, once they reach the end of their lifespan, they will slough off and fall into the urine, right? They will fall into the urine. So if this hemosiderin containing PCT cells fall into the urine, what do we call it? What do we call it? Excellent. Hemosiderinuria. Right? Now tell me this, what do you all think? When there is hemolysis, will acute hemolysis give rise to hemosiderinuria, or will long-term chronic hemolysis tend to show hemosiderinuria more? What do you all think?
Chronic.
Chronic, why? Why?
Because it's stored for a long time.
Excellent. Just that, guys, from here, from apoferritin, when it stores into ferritin, for all the ferritins to get filled up and then for them to aggregate and form hemosiderin, for all of these processes, it takes time, right? It takes time. So this hemosideruria, if you see it in a patient, what does that indicate? Hemolysis has been going on for a while, right? Okay, so it takes time. Okay. Then on the other side, what you said is correct. Toxic effects can be there, especially if now the storage ability is maximized. If they have used up all of their ferritins, if their cells, PCT cells are full of hemosiderin, then what happens? No more storage ability. So there can be toxic oxidative damage, we call it, guys. Oxidative damage, right? Oxidative damage, and that results in what we call acute tubular necrosis. Acute tubular necrosis, right? We have talked about this in our renal chapters, right? This gives rise to renal failure. Okay, right? Okay, so this is a little bit about this intravascular, because it's a little bit intravascular hemolysis. The way it affects the body is a little bit different from extravascular, right? Okay, extravascular hemolysis, do we get hemoglobinuria? Do we get hemosideruria? No, right? We don't get, right? Why? Unconjugated bilirubin is bound with albumin, and that cannot leak into the filter into the urinary system, into our nephrons. Okay, I hope you all remember those. Try to piece the story together. Today is a lot of mechanisms, guys. If you all understand the mechanisms, understanding the disease very easy. Okay, then we will do one more, the last question, and we'll take a small break and come back, right? Look at this. The last question we need to ask ourselves, question number 4, right? What we need to ask ourselves is this acute or chronic hemolysis, right? Acute or chronic hemolysis, right? This is the last question. Now here, we already know certain things, right? Especially about the IV hemolysis. We'll talk about this guys. What if it is chronic extravascular hemolysis? If it is chronic extravascular hemolysis, there is one feature that is important that I want you all to understand. Now tell me this, if it is chronic extravascular hemolysis, chronically, what will be high in the blood? Chronically, what is high in the blood?
Unconjugated bilirubin.
Excellent. Chronically, you all can write down, chronically, unconjugated bilirubin is high in the blood. If chronically unconjugated bilirubin is high in the blood, what is happening? Chronically, a lot of unconjugated bilirubin keeps coming to the liver, keeps coming to the liver. So what is happening? Conjugated bilirubin in the liver is going to be what? Chronically, it's going to be high. Right? Conjugated bilirubin, guys, in our biliary tree, if you remember, as they are produced, the excess amount, some of it will be stored, right? Some of it will be stored, some of it will come into the digestive tract. Where will some of those conjugated bilirubin be stored? You all remember the biliary tree? Gallbladder. Some of the conjugated bilirubin will be stored. So chronically, when there is hemolysis, chronically these gallbladder stores conjugated bilirubin storage, right, in the gallbladder increases over time. And when there is a chronically a lot of aggregation of conjugated bilirubin in the gallbladder, what does it eventually result in? Gallstones, right? Okay, gallstones, right? This is one important. The other manifestations of acute extravascular hemolysis we've already talked about, right? The mild jaundice, those kinds of things, right? Dark stools, those kinds of things. This chronic extravascular one is a little bit of a special one because we have gallstones there. Then the second one, what if it is IV, intravascular hemolysis, right? Intravascular hemolysis. If it is acute, guys, what do we have? First thing we can have hemoglobinuria. Hemoglobinuria. Hemoglobinuria, right? Then what is the other thing? What test is positive here? What test is positive? Huh? What test is positive?
Comes.
The Shams test, right? Shams test positive. What does Shams test detect? What does the Shams test detect? Huh? Tell words. Met what?
Hemoglobin.
Methemoglobin.
Methymalbumin.
Methemalbumin. Methemalbumin. Okay, not methemoglobin. Okay, methemalbumin. Right. Then, if it is chronic, guys, one thing I want you all to know: what can you all check for in the urine? Huh? What can you check for? Hemosideриnuria. This is an indication of chronic. Okay, and they can also show the Shams test positive. Hemosideриnuria is much more specific for the chronic form. Okay, right? Is everyone clear up to this point? All good? Right? Right, excellent. Now we will take a short break, a 10-minute break, right? And come back, right? Then we will discuss autoimmune hemolytic anemias. Okay? Right. Right. Is everyone back? Okay, shall we start? Then your camera is on. Share screen. Right. All right. If your electricity is off, it's okay, huh? Yeah, we're having some issues now these days. What to do? Right. Okay. Now we will start our discussion about autoimmune hemolytic anemia. This is our main discussion for today, right? It's the main discussion for today. But now we have done the major part of it, right? Look at this, guys. What do I mean when I say this autoimmune hemolytic anemia? What we are basically talking about is there are antibodies that are against our RBCs, right? Antibodies against our RBCs that are going to bind to the RBC and then induce hemolysis. Now, this hemolysis induction can be done in multiple ways, right? We'll see different mechanisms how hemolysis is going to be induced. But the basic is that there are antibodies against our RBCs, right? These antibodies that are against our RBCs that induce hemolysis are almost always IgGs or IgMs, right? IgM, right? These are the two major forms. Right? We'll see how they function, what happens. Just before we move on, if I want to just mention, if you all remember, IgGs, guys, they are monomeric, right? If you all remember your third year, second year work, IgGs are monomeric, right? Monomeric. Whereas IgMs, you all remember what the structure is like. It's a pentamer, right? It's something like this, right? Just keep this in mind. You will see where we can apply. Huh? Right. Then the next important point I want you all to know, guys. So now we have our RBC, right? These are our RBC. And on our RBC membrane, guys, we have some proteins. Now these can be proteins related to our ABO system, or they can be proteins from our RH system, whatever it is. On the surface of our membrane, we have special structures. These are sometimes proteins, sometimes they are carbohydrates, especially when it comes to the blood grouping systems, they are carbohydrates, right? These act as antigens for these antibodies. So what will happen? Antibodies against the RBC will come and bind to these, right? Antibodies will come and bind like this, right? When antibodies come and bind, right? One thing that can happen, don't worry, we are going into the depth, I'm just going over it roughly, right? One thing that happens is it causes what we call sticking together of RBCs. We call this agglutination, right, of RBCs. This is one thing. Another thing that can happen, guys, once the antibody comes and binds like this, right? In some situations, some antibodies are capable of activating and fixing complement. We say complement fixation onto the RBC. So for example, if the RBC is like this, now this antibody came and bound. Usually we need about 2 antibodies, guys, to come and bind in order to fix complement, right? And they will start this complement fixation. If you all remember, it starts at the FC portion, right? The C3, C3b, right? Like that, it goes C4, right? And then C5, C6, C7, C8, eventually C9. This is the membrane attack complex, right? Okay. So these are 2 methods of how they happen. One is the agglutination can happen. So RBCs will clump together, right? RBCs will clump together. The other type is complements can be fixed and then the RBC will be destroyed. Now, the important thing I want you all to know here, guys, if, write this down, if, you can put a star, complement fixing ability is strong. If the complement fixing ability is strong from these specific autoantibodies that are attacking, if their complement fixing ability is strong, what will happen, guys? Within the blood vessel itself, these membrane attack complexes will form and they will hemolyze the RBC. So what form of hemolysis will occur? What do you all think? Intravascular hemolysis will occur. If the complement fixing ability is strong. If the complement fixing ability is weak, right, or does not occur, or does not happen, right, either of the two, what do you think will happen? What will happen? The antibodies still come and bind, but the complement fixation is weak or not happening. Here we get extravascular hemolysis, right? Because the antibodies have come and bound, we will see what is going to happen, right? They will be taken up by the spleen and there we will see what will happen, right? Is everyone clear with this? Right? I want you all to get a very clear picture of this. Based on the ability of complement fixing, the location of the hemolysis can change. Okay, this is the first most important concept, right? Right. Now, if it is weak, what is happening? Extravascular hemolysis. So what is happening in this extravascular hemolysis here, guys? When it is autoimmune, what do we have? We have an RBC, right? Especially to its carbohydrate structures and sometimes protein antigen structures. These antibodies have bound like that, something like this, And when they come into the spleen throughout their normal circulation, when they come into the spleen, they are highly attractive to splenic macrophages. Why? Splenic macrophages, guys, they have receptors for these FC portions. So they can bind like this, right? They can bind like this. Okay, to the FC portions of the autoantibodies, right? So splenic macrophages, splenic macrophages, right? Now, this can result in two things. Look at this, very simple, very simple. One thing, when the macrophage is attracted like this, what will it do? It will engulf this. It will engulf this. So inside the macrophage, macrophage will be very, very happy. Nom, it ate that RBC. Now the RBC is here, right? And it will be broken down. Okay, it will be broken down. This is one possibility. The other possibility, guys, especially if this is a very young, very flexible RBC, right? Who can run around a lot, not nearing its 120 days. Let's say it's just 5 days old. It's a very young fellow, right? Those kinds of RBC, what will they do, guys? They actually do a sort of a heroic act here, right? What they do is, guys, they run away. They run away from this binding, but they break off their own membrane pieces and leave them there. So for example, these 3 pieces will be left here, right? These 3 pieces will be left here, right? And resulting in something like this. Let me draw it like this, make it clear for you. Right, these 3 pieces will be left, right? And this remaining portion will run away. So now what happens, right? Some part of the membrane has been lost. The rest will reconnect, and they will run away, right? They will run away. Okay, so, right? He's putting his tongue out and he's running away, right? Okay, right? These will break free. Now, what is the important thing I want you all to understand? This happens in extravascular. This happens in extravascular in the spleen with the macrophages. What is the important thing I want you all to know here, guys? Look at this. Now, what was the initial shape? A nice biconcave disc, right? Something like this. Now, let's say this piece, a piece from here, removed, right? As it detaches from the macrophage, what will happen? Right? Right, look at this. Let me draw it step by step so that you all understand. This piece will be detached, right? This piece will go away. What will be the result here? The remaining bits of the RBC membrane will join together. Whatever is remaining will join together, right? Then, guys, what do you think happens to the biconcave? Can it still maintain that biconcave shape and join together? No, now it will be something like this, as those pieces came together, right? So this is after one interaction with a macrophage. Let's say again that blood cell, the same blood cell went around the circulation, came to the spleen, again met with the macrophage. Why? It still has these antibodies bound to it. It still has antibodies bound to it, right? Still has antibodies bound to it. So now what happens? Another piece of RBC will be removed. Let's say somewhere here will be removed. Eventually, guys, what happens? This RBC loses its biconcave shape and becomes sort of like an egg, like a spherical shape, biconcave shape loss. This is what we call a spherocyte, guys. Spherocyte, right? So in extravascular hemolysis, in the blood picture, right, we can see spherocytes. In intravascular hemolysis, no, we don't usually see spherocytes, right? Okay, extravascular, yes, right? Okay, so this is some basic concepts about this autoimmune hemolysis. Now, why is all of this happening? Because autoantibodies have come and bound to them, right? No other reason. Autoantibodies have come and bound to them, right? Right? Okay. Now, let's go further into our discussion, right? Autoimmune hemolytic anemia, guys, it can be classified into two types based on the temperature at which these antibodies are maximally active, right? At which these antibodies are maximally active, right? So we have basically two types. Look at this. The first one, based on the antibody, the temperature, the maximum activity temperature, right, of the antibody. So we have two types. One, right, I will write it in red, right? One, this is for warm antibodies. Warm antibodies. What do we mean by warm? These antibodies are maximally active at our normal body temperature at 37 degrees Celsius, maximal activity, right? So these warm antibodies, they give rise to what we call warm autoimmune hemolytic anemia, or some people call it warm acquired immune hemolytic anemia, right? Same thing, right? From the warm antibodies, right? This is, guys, actually majority of our autoimmune hemolytic anemias. About 80% of our AIHAs are warm type, right? So cold type is only a little bit, right? Cold type is only a little bit, right? And these ones are primarily, almost always, IgG molecules. These antibodies, these warm antibodies, are almost always IgG type, right? IgG type autoantibodies, right? Okay, right? Then what is the other one, right? Cold antibodies. Cold antibodies. These ones, guys, their best activity is at 4 degrees Celsius. But do humans ever, do our core body temperatures reach 4 degrees Celsius? No, their best activity is at 4, but they can work anywhere under 37 degrees, anywhere up to 36.9 they can work, right? Their highest activity rate is at 4 degrees Celsius, but they can work anywhere under 37 degrees Celsius. That's why they are relevant to humans. Otherwise, if they work only at 4 degrees Celsius, will we be bothered about cold antibodies? No, our core body temperature, if it goes to 4 degrees Celsius, right, in the freezer, no? Right, look at this. These ones, guys, these are a minority of the cases, only about the remaining 20% of autoimmune hemolytic anemias, right? You don't meet them a lot. You won't find a lot of patients with this cold type. What does this give rise to? Cold autoimmune hemolytic anemia, or cold acquired immune hemolytic anemia, same thing, right? Right. And these ones, the important point, are primarily IgM. These are primarily IgM. These cold antibodies are primarily, mainly IgM. Guys, remember when I say primarily, majority, 90-95% of the case, rarely there can be other forms of immunoglobulins coming in. We don't need to discuss those, not for our MBBS, right? Primarily, warm is IgG, cold is IgM, right? Okay, right. Don't worry, I will tell you all the mnemonic later, right? Now, so we'll start off with the first one. Warm autoimmune hemolytic anemia. Warm acquired immune hemolytic anemia, same, right? Warm one, right? Look at this, guys. These ones, what did we say? They are caused by IgG molecules, IgG antibodies, and especially, guys, especially they are IgGs against the Rh antigens on RBCs. On the RBC, guys, you all know we have several different types of Rh antigens, right? We have an E, we have a P, we have H, right? We don't need to talk about those. Just know, right? They are against Rh antigens on our RBC, right? These antibodies, they are IgG type and against Rh antigens, right? Now, look at this. The exact etiology of the primary disease, guys, we don't know. We call it idiopathic. We don't know why these antibodies are being produced. We don't know the exact etiology of the primary disease. We don't know. So we call it idiopathic. But we do know some associations. Secondary disease. The secondary disease, that means due to some other disease, warm autoimmune hemolytic anemia occurs. That means warm IgGs, warm immunoglobulins, warm antibodies are being produced. Those relationships we have found out, guys, associated with certain autoimmune diseases. For example, SLE. For example, rheumatoid arthritis. With these conditions, we also see some patients tend to have these. We don't know why. We don't know why exactly. But together with these autoimmune conditions, we have found the association. These are seen. Now, if it is seen a lot in these autoimmune diseases, who is mostly affected? Males or females? What do you all think? No? I did SLE for you all, no? Who is affected more? Answer.
Females.
Females. Autoimmune diseases, we've talked about. We've even discussed several hypotheses as to why this happens, right? So, in the same way, guys, warm AIHA, females much more common than males. Okay, females much more common than males. Okay, right? Then there are some other diseases these are associated with. For example, guys, we'll talk about this CLL, right? We'll talk about this CML and CLL in this module. Towards the end of the module, we have some lectures regarding those and certain lymphomas. We are going to talk about lymphomas as well, right? In this module, right? Lymphomas. We'll talk about those later, right? No need to put them here. Basically, what I want you all to understand here, why these diseases are associated with these autoimmune conditions, they cause these diseases through some mechanisms, they cause B lymphocyte dysregulation, right? So what is going to happen? Autoreactive B cells will be activated and they will start attacking our own body cells. One type of cells, they attack other RBCs. If you all know that much, more than enough, right? Nothing to excavate there more. We'll go to the third one, guys. Certain drugs can induce this warm autoantibody formation. How? Look at this, guys. We'll talk about 3 specific examples. One, right? Either the drug or its metabolite interacts with the red blood cell surface antigen. So for example, guys, now let's say this is my normal RBC. This is my normal RBC and I have some antigens, right? I have some antigens here. Now what happens, guys, when I take the drug comes and it alters the shapes of some of these antigens that are present on the RBC, right? It can be either the drug or its metabolites, right? Drug or its metabolites, right? And it will modify this so much, right? It will modify these antigens so much. Now they look very different. They look, let's say, something like this, right? They modify these antigens so much that our own immune system now detects that RBC as a foreign, right? As a foreigner. Therefore, what happens? Immune system starts attacking. Especially, guys, this is noted with penicillins, right? Penicillins have the ability to do this, right? Okay. Penicillins have the ability to do this, right? Then another way, how can drugs cause this autoimmune reaction to start? Another thing is, guys, the drug structure, right, is similar to the RBC membrane antigen. So let's say the RBC membrane antigen was a nice, okay, let me draw a special shape, right? Something like this. This was just to make you all understand, there is no antigen like this, like a, yeah, I don't know what that is, right? That shape, right? So the RBC membrane antigen is that shape. Now what happens? The drug itself is also this shape, right? So what will happen when you give the drug? Our immune system will be primed and it will start coming and attacking this. It will start producing antibodies against this drug. But at the same time, what is happening? That shape is very similar to the shape of the antigens on our RBC. So these antibodies will start cross-reacting and attacking our own RBCs as well, right? This is another thing, right? The structure of the drug is similar to the RBC membrane protein and therefore induces. This happens, guys, especially with methyl-dopa. Methyl-dopa is what kind of a drug is methyl-dopa? What is the class? Is a anti-hypertensive. Is a anti-hypertensive medication, right? Methyl-dopa. Okay. Right. Okay. Is that clear? Right. These two, if you all know, more than enough. There are other mechanisms, guys. There are a lot of mechanisms how drugs can induce autoimmune reactions. We don't need to talk about this. If you all know these two, more than enough. Penicillin and methyl-dopa is enough. Right. Then, so we'll come back to our warm autoimmune hemolytic anemia. The next one I want you all to know, right? We can do a special test to diagnose this autoimmune hemolytic anemia, right? This is called the Coombs test. For now, write it down. Direct Coombs test will be positive. Direct Coombs test will be positive. Okay, Coombs test will be positive, right? Okay, now, before we go into the diagnostics and the further treatment and everything, let's talk a little bit about this Coombs test. What is this Coombs test? How is it done? Okay, what is the mechanism behind it? Look at this, guys. Coombs test, basically, right? You all can put it as a note, note. Coombs test, right? Coombs test, guys, there is basically two. We have a direct and we have an indirect. Right? Let me come here. Let me do it here. Okay, look at this. Direct and indirect. What is this Coombs test, guys? It is nothing special. It is a test that detects anti-RBC antibodies. It is a test that detects anti-red blood cell antibodies. How does it do that? How does it do that? Look at this, guys. First thing, we have to manufacture this Coombs reagent, right? That is what we need for this Coombs test, right? How do we manufacture this Coombs reagent, guys? We take a person who is already having these autoimmune conditions, right? These are already done in the labs. We don't need to do this. You don't need to take a person, right? You take someone who is already producing these autoantibodies, you take his blood and you take his serum, right? So his serum will have what, guys? His serum will have immunoglobulins that are against the RBCs. His serum will have immunoglobulins that are against the RBCs, right? You take this serum and we inject it into an animal, right? Let's say a rabbit, right? We inject it to a rabbit. Okay. We inject it to a rabbit. Now look at this. So these ones are here, right? Now, at the same time, guys, now what did we say? Some antibodies in these autoimmune states, they can induce complement activation, right? They can induce complements, right? So some of these complement proteins also can be taken from the serum, right? Some complement proteins also we will take from the serum, right? Complement proteins, right? And those also we will inject with the same injection. So now what does the rabbit have? Rabbit has immunoglobulins against human red blood cells, and rabbit has complements against human red blood cells, right? Okay. right? Rabbit has both of these. What now? These substances, when you inject it to the rabbit, does the rabbit's immune system know these? Have they seen these before? No. They are going to identify these as foreign molecules. What are they going to do? They are going to produce antibodies against this. So for example, they will produce antibodies against these anti-human RBC immunoglobulins, and they will produce further some more antibodies against these complements, against these complements. Once this is done, guys, we extract the rabbit's serum. We take out the rabbit's blood, some of the rabbit's blood, right? Some of the rabbit's serum, and we extract these antibodies. So it will be, what are we left with? We are left with this blue one, right? The blue one and the yellow one, right? Right, like this. Okay. Right. What are these, guys? What is this? What is this mixture? This is what we call the Coombs reagent. Coombs reagent. So if you add Coombs reagent to anyone's blood who has autoantibodies, what will happen? Immediately they will go and bind. If you add Coombs reagent to anyone's blood who has complements against the RBC, immediately they will go and bind. Okay, right? Right. So now we have created the Coombs reagent. Right. Look at this. Now we will see how we can utilize this. Look at this, guys. Normally, in a normal person, if you take a normal person's blood, right? We know our RBC membranes, guys, they are negatively charged. They are negatively charged molecules, right? RBC membranes are negatively charged, right? This, we call it a zeta potential, right? We don't need to discuss here, right? What they do is basically, because of this negative charge, it prevents RBCs naturally clumping together, right? So self-agglutination is just stopped because negatively charged, it will repel, right? Therefore, now let's say by some mechanism, the patient has some autoantibodies, Let's put it in a different color, a black, right? Autoantibodies have come to this patient's RBC, right? Autoantibodies. Okay. And some of this patient's RBC, right? Some other RBCs also have these complement attached to it. Complement proteins that have been attached to it, right? Now what happens when we put the Coombs reagent here? When we put the Coombs reagent here, what happens, right? What happens is, guys, the obvious thing, right? You can draw multiple of these, right? When we put the Coombs reagent, guys, the Coombs reagent will come and immediately bind with these, and they will start agglutinating them one to another, right? They will bind like that. They bind to the FC portion of the autoantibody and to each other. They can bind to each other, right? So they start agglutination. Same with the RBCs that have the complements, Same with the RBCs that have the complements. Let me draw that also, because they have something like this, no? So against the complements, we have the yellow color, right? So this will come and bind. Let me draw it nicely. One thing here, and another one here, another one here, another one here. Right, like this, they will come and start aggregating these RBCs together, clumping these RBCs together, right? By cross bridging, the antibodies, guys, from this Coombs reagent, they cross bridge, right? Eventually, the mass increases and they start settling at the bottom. These RBCs, since they clump together, they start settling, they become heavy, right? They start settling at the bottom, right? This is what we call agglutination. Agglutination. So this is a sign of positive Coombs test, right? Positive Coombs test, right? Now in this test that we just performed, right? In this test that we just performed, what did we do, guys? Coombs reagent was directly added to the blood sample, right? This blood sample was taken from a patient, patient blood sample, right? Coombs reagent was taken, directly added to the patient's blood sample, and it clumped. So it got a positive Coombs test. When we add the Coombs reagent like this directly onto a blood sample, this is what we call a direct Coombs test. Direct Coombs test. And what does the direct Coombs test detect, guys? Right? It is used to detect autoantibodies, right? That are present, autoantibodies or complements, you can say complements, both, that are present on the, write this down in red color, on the RBC surface, right? The direct Coombs test is used to, now you will understand this further when we talk about the indirect, don't worry, right? It is used to diagnose, right, autoantibodies or complements on the surface of the RBC itself, right? Okay. Right? Okay. Understood. Guys, turn your cameras on. Only 3 are turned on. If you don't have electricity, it's okay. If not, just so I can get some feedback. Right? Look at this. So everyone good with this? Direct Coombs test, all good, right? Understood? Right. Then what is this indirect Coombs test? What is this indirect Coombs test story? Right? Look at this. Right? You can see the board. No? Let me come here. Now we will come to this indirect Coombs test. Right? Indirect Coombs test. Right? What is happening here? Look at this, guys. We will talk about it with a clinical example. Let's say, then you will understand it nicely. Let's say we have a pregnant mama, okay, pregnant female. Just draw, right, a uterus like that, right? She's pregnant. Okay, and who is inside? Boss baby is inside. Okay, baby is inside, right? Okay. Now I'm telling you all, this mother, she has, her blood is A negative, right? A negative. So what does that tell you, guys? On her RBC, if you look at her RBC, she has A antigens. She has A antigens. A antigens, right? And what do you think about her rhesus antigens? Does she have RH antigens? Does she have RH antigens?
No.
No, she does not have RH antigens, right? So she just has the A antigens. Now look at this, right? Now let's say this mother got pregnant, right? And her husband has a RH positive blood group, right? We don't need to know the exact blood group. We just know it's RH positive. So this baby is now an RH positive baby, right? RH positive baby. Okay, RH positive baby. What is going to happen, guys? During the final stages of labor, right? Some of the fetal blood can mix with the maternal blood. Some of the fetal blood, especially during delivery, a very small amount, not a large amount, a very small amount of the fetal blood can mix with the maternal blood. Okay, right? They can get into the maternal circulation and mix. What is going to happen, guys? So this baby has Rh positive on their RBC. They have this special Rh antibody. Rh antibody is there. Sorry, Rh antigen, Rh antigen, not antibody. On the baby's blood cells, they have this Rh antigen. So when this blood cell comes into the maternal circulation, the maternal circulation is going to detect this as foreign, right? Because the mother has never had an Rh antigen, right? It's seeing this for the first time, and it is going to start producing antibodies against this Rh, right? Against this Rh, right? But now this happened when? During the final stages of the labor, right? So what has happened now? This happy baby has come out. Okay, happy baby is there crying. He has come out. So is there any bad effect for this baby from these newly synthesized antibodies? No, he's already out of the body, right? No issues, right? It's already out of the body, right? No issues, right? Now, however, mother's immune system is now primed. It is primed. It has this inside the mother's circulation. I will draw inside the mom, right? Some anti-Rh antibodies like that, right? Now what happens? After a couple of years, the mother has a second baby, right? Second baby from the same husband. Okay, or a different husband with a Rh positive group. No judgment, right? Now, right? What happens now? Again, we get the second baby who is, I will draw the second baby in another color, say green. Second baby who is also Rh positive, right? Rh positive baby, another Rh positive baby. Now what is the problem? Mother already has what? Antibodies against the Rh, right? Mother already has antibodies. So these antibodies can cross the placenta, right? They can cross the placenta and come here and start attacking the baby. It can cause some hemolysis in the baby, right? So when we take the second baby out, guys, when we take the second baby out, right, they might be manifesting some hemolysis, right? So they will show some jaundice. This is what we call hemolytic disease of the newborn, right? Okay, right. Now look at this. Now when this second baby is being born, right? When this second baby is being born, what happens, guys? Again, during labor, some of the fetal blood gets into the maternal circulation, right? So what is happening? Mother's immune system again primed. Now it will make even more antibodies against the Rh, right? Now mother has a lot of antibodies against the Rh, right? Mother has a lot of antibodies against the Rh. What will happen if the mother has a third child? Now this was already showing hemolysis, right? When they were born, right? Now what will happen? Third time, highly unlikely that it will be a successful pregnancy, right? So therefore, isn't there a way we can detect this, right? And isn't there something we can do about this, right? This is the important thing I want to teach you all. Now look at here, guys, before we go into all the detail, let's say we take one of these babies. These babies, you all know, they come with the umbilical cord, no? Right? Umbilical cord. If we take some cord blood, right? We take some cord blood out, and what do? Right? We take it onto a slide. Guys, we'll take this second baby. Forget the first baby. We'll take the cord blood from the second baby. Second baby is cord blood. First baby, leave him aside. He was fine, right? He was born fine, no issues, right? Second baby's cord blood we take, we put it onto a slide. Now, what will the second baby's cord blood have, guys? Just tell me. The second baby's cord blood, what will he have?
RH antigen.
RH antigen.
Yes.
What does he have? Yeah, correct. He has the, because he's a RH positive blood group. Yes, he will have, let me draw the RBC in red. Yes, he will have the, let's say I'll draw 3 blood. So he will have, yes, you're correct. He will have the RH antigens, right? Because he's a RH positive. What else will he have in his blood? The second baby. Huh? Guys? Tell, answer.
Anti-RH antibody.
Yes, he has anti-RH antibodies as well. Those have come and now bound. That's why he was getting hemolysis, right? That's why he was getting hemolysis, because these anti-RH antibodies from the mother came and bound to them, right? So if you take the cord blood and look at it, you will see this. You will see this, right? Now, what can you do to this cord blood? Now, you cannot directly see this, no? How can you diagnose this? What can we do? We can add what? What can we add here? What can we add here? Coombs reagent. Coombs reagent. When we add Coombs reagent here, what will it show? What will it show? Huh? What will it show? Sorry? Agglutination. Yes, clumping. Correct. Clumping. Agglutination. Right? Okay. This is what, guys? This is a positive. What?
Coombs test.
Yeah, what Coombs test? Direct or indirect? Huh? Is this indirect? What did we do? We have, this is the direct one. This is what we discussed. This is direct. This is a direct Coombs test. Why? We directly add the Coombs reagent onto the RBCs that already have, right? On the RBC surface itself, antibodies are there. So this is what we can do with the fetal cord blood, right? This is what we can do. What about the mother? Now let's say the mother, right? Now let's say the mother just had the second child also, who is who had some hemolysis. Now what should you tell the mother, right? Third child, if you're planning to have, there is an issue. You should first come to for counseling. We have to first do some testing and see, right? So let's say after about 3, 4, 5 years, the mother comes to you and say, okay, doctor, I want to have the third child. Now what do we want to do, guys? What we want to do is we want to test and see if the mother still has these anti-RH antibodies. Correct? Everyone agrees? We want to test that and see. If they are there, we can warn the mother, okay. Now, first thing, we have to get rid of those antibodies, then you can have the child. Before that, no, right? Right. How can we do that? How can we do that? What we do is, guys, now we take some of the mother's blood. We take some of the mother's blood. What does the mother's blood have, guys? If you look at the mother's blood, right? She was A negative, no? Right? She will have the RBCs. She will have the RBCs with the A antigens, right? And what else does she have now after her first and second pregnancy? What else does she have in her blood?
Anti-RH antibodies.
Anti-RH antibodies. But are those anti-RH antibodies bound to her RBCs? Does she have RH? She doesn't have RH. She's a negative. So she will have anti-RH, but they will be separate. They won't be bound to the RBC. They will be like this, right? They will be like this, right? Now, so now if we, what can we do? If we add Coombs reagent directly to this, will it work? Will it show you clumping? If you add Coombs reagent directly to this, no. Why? These antibodies are separate. They are not on the RBC surface. So doing Coombs reagent to this, useless. But we have a workaround, right? This is our indirect Coombs test. What we can do? What can we do, guys? So we take this maternal sample, right? We take this maternal sample, and to this, right? To this, we add some Rh positive blood that is already there in the lab from another human. We have already collected Rh positive blood in the labs. They already have. We add some Rh positive blood, right? Let's say this is a positive person, right? So what does this person's blood have? The blood cells rather, what do they have? They have the A antigen, and they have the Rh antigen, right? This one. They have both the antigens there. Now the Rh antigen is what we want. Forget the A, we don't need the A. We take this one and add it to this, right? We take these blood cells and add it to this maternal sample. So we are basically, guys, mixing blood. We are basically, what we are doing is mixing blood. Now, the moment you put this other human's RBC into this maternal blood, what will happen? This is Rh positive blood. So the anti-Rh immunoglobulins will go and bind to the Rh groups, to the Rh antigens. Is everyone clear about this? Guys, unmute and talk. Is everyone clear about this?
Yes.
Yep.
Right? Okay, excellent. Now, what can we do as the next step? Now, what do we have? We have RBCs that have bound on its surface with antibodies, autoantibodies. Now, what can we do? What is the next step?
Coombs reagent.
Add Coombs reagent. Now we add Coombs reagent, right? That will give you a positive. It will show clumping. Right? That is a positive Coombs test. This is an indirect Coombs test, right? Indirect Coombs test positive. And this is, guys, what does it detect? It is basically to detect antibodies against the RBC in the serum, in the maternal serum, not antibodies that are connected to the RBC. Okay. So this is indirect Coombs test, right? Okay. Did everyone understand direct versus indirect? Why we call it indirect? It's an extra step. You add someone else's blood, an Rh positive blood first, then you do the Coombs. So it's an indirect. In the first one, you directly add the Coombs, so it's direct, right? So then if this clumping occurs, what can we tell the mother? You still have the antibodies from your first and your second pregnancy, right? Therefore, we'll have to first get rid of those. And then, right, if you really want the pregnancy, you can do it. Otherwise, we suggest not, right? Especially if the second child had severe hemolysis, guys, right? Only if they really want to do it, there are some methods we can get rid of these antibodies. Not our topic today, right? All good, right? So that is the direct and indirect Coombs. Now, one thing I want to mention here, right? These antibodies, guys, these antibodies that were in the maternal circulation, right? Why were these produced? Because was it the mother's own red blood cells that stimulated this production? Is it something of the mother's own body that stimulated their production?
No.
No, it was the baby's blood that stimulated that, right? Because of that, the baby is also human, no, guys? When some organism of the same species stimulates an antibody production, we call it alloantibody. Alloantibody. So this one, instead of autoantibody, right? We just call these antibodies alloantibodies. If it was autoantibody, what is it? I myself, from my immune system itself, my cells itself, cause the production of an antibody. That is an autoantibody. Allo is something else, but in the same species. Say it has to be a human, right? So this time the baby is a human. So baby is the one that caused it. So this is an example of alloantibody reaction, right? Again, this can cause hemolysis, right? So if you look at your table, guys, the table in your notes, the very first table, right? There, what I have put there In the acquired hemolytic anemias under immune, we get autoantibody and alloantibody. So this hemolytic disease of newborn is an example of alloantibody. Alloantibody, right? So here we discuss two things. One is the hemolytic disease of newborn, and the other is the Coombs test. That is very important for our discussion, right? Did everyone understand Coombs test? Right? Okay. Right. Let's carry on. Right. Let me share the screen. Right. So direct Coombs test. Okay, I can't see you all. Where are you? There we go. Right. So what did we were talking about warm autoimmune hemolytic anemia, and what did we say? They show the direct Coombs test positive, right? Okay. So that's about it for warm autoimmune hemolytic anemia, guys. Just the management part. Now we'll come to the management, right? Management part. What can we do? What can we do? What is the first thing? What is the first thing to do here? What is the first thing to do here?
Immune suppression.
Before immune suppression, guys, the most important thing, treat the underlying cause. Underlying cause. For example, if it is drug induced, what do? Remove the drug. If it is a drug induced one, remove the drug, stop the drug. Or if it is a drug that cannot be removed, right? You can either switch to another drug in the same class or taper the dose or whatever. Either way, if it is the drug induced, the best thing is to remove the drug. Remove the drug. Second option is, yes, you're correct. We can do some immunosuppression because this is autoimmune. This is an autoimmune condition. And do some immunosuppression, right? What are the examples, guys? Exelon. What is Exelon? Methylprednisolone, huh? Methylprednisolone. Hexilon. Then in a little bit more severe cases, we can use something like azathioprine, right? Cyclophosphamide, right? These kind of things. Usually, guys, these we give for about 3 weeks. And then for the next 10 weeks, we can taper the dose. Taper, right? This is your clinical knowledge, right? Right. Now, here, guys, some important things. If the hemolysis is considered severe, when do we consider hemolysis severe, guys? If it is severe, right? When do we consider the hemolysis to be severe? Right? That by definition, one is if the patient develops heart failure. That means what? Hemolysis is severe. That is one thing. The second one, if there is a drastic reduction in HB, right? Somewhere around 0.5 milligrams per deciliter per day, right? If they are losing, that is a very severe hemolysis, very severe hemolysis. If these things happen, guys, if it is this severe, we have to give blood transfusions, right? Now, what is the important thing here? Make sure as much as possible, obviously, if it is a very rural area and a very worst case scenario, we cannot look for this. But whenever possible, make sure the transfusion is matched, okay, as much as possible. If it is an A negative, try your best to give an A negative blood, right? Because what will happen if you give another one? Further hemolysis, transfusion reaction, alloantibody, right? Okay. Then the final option, the final option we have, if nothing is working, right, is a splenectomy. Splenectomy. Okay, this is, we leave it for the last option. Okay. Right? Okay. So here, one thing, if you all want to remember, right? I also found this from somewhere else, right? Girls are hot. Okay. What is this? IgG, right? And RH. They are antibodies, especially against the RH, right? And hot. Hot means what? We are talking about warm, right? Warm autoimmune hemolytic anemia. Okay. Right? If y'all can remember that, it's great. Then we come to the final one, guys. Cold autoimmune hemolytic anemia. Anemia, right? Right. Okay, cold one. Now, what do we know about the cold one up to now? It is mainly an IgM. It is mainly, and first thing, it's not very common. Warm autoimmune hemolytic anemia is much more common, right? This one, not so much. It is an IgM, guys, right? So this is what? This is a pentamer, right? This is a pentamer, something like that. Okay. Again, guys, if you look at the causes, right? Primary disease, again, it's idiopathic. We do not know what is causing this, right? Primary disease. Why these cold antibodies? Now, the cold antibodies, guys, it is active at what temperatures? Anything less than 37. Anything less than 37. Okay, right? From 4 degrees for anything less than 37, right? Then secondary causes, guys. Secondary causes. Those who came from my respiratory classes. We all remember any form of pneumonia that is associated with this cold agglutinin disease. Any form of pneumonia. I gave you all a mnemonic also. Anything? Tarinder? No?
Is a new system, Old Rbc or something? No.
No. Remember, mind, cold, plus ma. What is this? Remember? No? Still no? Go back. Look at your notes. Mycoplasma pneumonia. I gave you all this mnemonic. Remember, mind. Why? It can affect. There are CNS effects, right? Cold positive. This is the cold agglutinin, the cold autoimmune hemolysis, right? And ma for multiforme, erythema multiforme. They have a rash, right? Okay. Go back to your recipe notes. Okay. Have to draw connections. Secondary causes, guys, one of the most notable is Mycoplasma pneumoniae, right? Okay, Mycoplasma pneumoniae, right? And then we have some others, infectious mononucleosis, right? Not very important, right? And we have others, guys, we are not going to talk about. Certain lymphomas, we'll talk about these in the upcoming chapters. And you all have already talked about paroxysmal nocturnal hemoglobinuria. This also can have these cold antibodies, right? Okay. Now, what is happening here, guys? This cold autoimmune hemolytic anemia is a little bit different to the warm one, right? Basically, how it works is a little bit different. Especially now, under normal body temperatures, we have 37 or a little bit higher. It doesn't usually go a little bit lower unless you are living in a colder area. That is exactly what happens here. In cold temperatures, just draw this, guys, especially in our extremities. Let's draw a hand. Let's draw a long hand like this. Right. 1, 2, 3, 4, 5. Okay, I do 6 fingers. Just draw a hand with 5 fingers. No polydactyly. Okay. Right. Let's draw a hand like this. Right. Okay. what happens, guys, especially in cold temperatures? In cold temperatures, what happens? These antibodies become active. Antibodies become active. These cold antibodies, the cold antibodies become active, especially at less than 37. Anything less than 37, right? Therefore, what do they do, guys? They do several things. One is when these cold antibodies become active, they are what did we say? They are mainly IgMs. They are pentamers, right? What happens, guys? So it's like this one, right? When these guys get active, they can naturally cross-link RBCs. Now what will happen? They will bind with RBC antigens at each of these sites, right? So RBCs naturally become agglutinated, right? Because why? These IgMs are now active, right? So this is, guys, agglutination happens here, especially in the extremities of the body. Agglutination, nations, right? You all know, guys, especially when you're going to the distal extremities, your fingers, your toes, and the tip of your nose, your ears, right? In these extremities, right, temperature is a little bit lower usually, right? Because the our body homeostatically tries to keep as much of the temperature, core temperature, in the center, right? Towards the extremities, it is less. So at these extremities, especially, these antibodies become active and they start agglutination. When they agglutinate in this way, guys, can these RBCs function? Can these RBCs function properly? When this agglutination happens, can gas exchange and everything happen? No. So what is going to happen, guys? Oxygen delivery to these extremities becomes less, right? Okay. This results in write this down in gold, Raynaud's like disease. Write the like in big letters. Why? This is not called Raynaud's, right? But it manifests like Raynaud's, right? Raynaud's like disease. This is what we call, guys, acrocyanosis. Acrocyanosis, right? What is this acrocyanosis? There is bluish purple discoloration of the extremities. There will be some numbness. It will feel cold to the touch, right? Just like Raynaud's. Appears like Raynaud's, but it is not Raynaud's. We call it acrocyanosis. What is the difference with this and Raynaud's? How does Raynaud's happen, guys? How does Raynaud's happen? How does Raynaud's happen? I have taught you. What is the mechanism? What is the what? Sorry.
Spasms.
Excellent. Raynaud's happens because of vasospasms. Right? The vessels are getting tiny and tiny, therefore blood flow is cut off. That's why the Raynaud's phenomenon happens. And that is also due to exposure to the cold, right? Here, due to exposure to the cold, there is no vasospasm, but there is a RBC agglutination that we call acrocyanosis. Right? Then, guys, now look at this. These clumped RBCs, so in the peripheries, it causes the acrocyanosis, right? Then, as they return to the central circulation, right, from the peripheral, when they return towards the core, two things can happen. Some of these will be free. Why? These cold antibodies become inactive again. The cold antibodies become inactive again, and those RBCs go free. This is one portion, some of these. Then there are sometimes, guys, some forms of agglutinins, when they come to the central circulation, right, they quickly, right, let's say this was the agglutinin, right, holding, let's say 5 RBCs like this. Once they come to the central circulation where the temperature is a little bit normal, right, they quickly activate complement system at the normal temperature, because complement system requires 37 degrees Celsius to be activated. They quickly activate the complement system, right, forms the membrane attack complex C5, C6, C7, C8, and finally C9, and they lyse the hemoglobin. They lyse the RBC, right? They break down the RBC, right? So what happens here, guys? Some of them, it's okay, but what is the major one that happens here? Intravascular hemolysis. Within the blood vessel itself, complement pathway is activated, right? Gives rise to hemolysis. Now, warm agglutinin disease. Warm agglutinin disease, it is mainly, guys, an extravascular form. Huh? Warm agglutinin disease, you all can write it there. This is mainly extravascular hemolysis, right? Mainly extravascular hemolysis. Cold agglutinin disease, mediated by the IgMs, majority of them are intravascular hemolysis. Majority intravascular hemolysis. Now tell me, if majority are intravascular hemolysis, right? What do we see? What do we see? What are the manifestations? What can you find in these patients? Tell me. If you look at the urine, what will you see? What will you see? Hemoglobinuria. How do you clinically see it?
Coca-Cola.
Cola colored, yes, cola colored urine, right? If you look at their serum heptoglobin, what happens? What will you see?
Undetectable.
Undetectable or very, very, very less, very less or completely absent, right? Then what is another test you can do? What is another test you can do? Huh? Shams test, CHUMMS test, right? Shams test. What does it detect? What does it detect? Huh? Answer. What does it detect? Sachit, what does it detect? Tell. Guys, what does the Shams test detect now?
Methymoglobinemia.
Methymoglobinemia. Why did it take so long? Did you all forget or didn't understand? If you all didn't understand, message after the class, right? Cola colored urine, all of these. And then sometimes also we can see the hemosideruria and all of these things can be seen. Here, guys, an important thing I want you all can put a star. One thing is special here. In these patients also, sometimes we can see an elevated MCV. But what is special here? We see very severely elevated MCVs. Say somewhere 130, 150, like that, right? 180. Very large MCVs. Why? Why do you think? Try to guess an answer. Try to guess, make a hypothesis. Try something.
Due to the bone marrow stimulation.
Not exactly. No. Look at this, guys. This is actually a laboratory issue, a technical issue. What is happening here? Look at this. These RBCs have become what, guys? Agglutinated, right? Our laboratory machines, they make the mistake, right? The analyzers, they detect these aggregates of RBC as one single RBC. This is why very high MCVs, right? Okay, actually, it's not that the RBC size has increased, right? But the analyzer, it detects it that way, that these cellular aggregates, agglutinated RBCs as one, it detects them as one, right? As a single RBC. So MCVs are very, very high sometimes, right? Okay, right? Then, now, here, when, what Coombs test can we do here, direct or indirect? What can we do here? What Coombs test can we do here?
Direct.
Yeah, direct. Why? We are trying to discover these, right? The antibodies that are already bound with the RBC cell membrane surface, right? So here, when we do the direct Coombs test, again, what is it? Positive, right? So warm and cold both have a positive direct Coombs test, right? Both have a positive direct Coombs test. Therefore, what other test can we do? We know already we can do the Shum's test. Shum's test, which will be positive in the intravascular type of hemolysis, which is most common with the cold type, cold agglutinin disease, right? There's another test we can do, guys. Another one very simple test. This is called the cold agglutination test. What do we do here? What do you all think we do here? We basically take the person's blood, we dilute it and put it to several test tubes, guys, the blood, right? We dilute it, put it to 5, 6, 7, 10 test tubes, right? And we cool each test tube to a different temperature to find out at which temperature best the agglutination is maximum, right? So maybe at about, let's say at about 20 degrees Celsius, agglutination is like this. At about, let's say 25, agglutination is much higher. So this is the best temperature, right? So just a diagnostic test, right? This is the third test that we can do, right? For the cold agglutination test, do we need to add Coombs reagent? What is the basis of this cold agglutination test?
No need Coombs reagent.
No need Coombs. We are just trying to replicate what is happening towards the extremities of this person. Same thing. As the temperature drops, agglutination happens, right? So that's exactly what we are trying to do in the lab, right? Just put it into test tubes, cool the test tubes. You will see agglutination, right? Right. How do we treat this? What is the management here? How to treat cold autoimmune hemolytic anemia? Again, guys, like the others, treat the underlying cause if we can find one, right? Okay, right. Second one, avoid exposure to cold. Avoid the exposure to cold, right? Now tell me this, steroids or splenectomy. Steroids or splenectomy. What do you think? Is it good? Is it a good option for us? Like in warm or what?
No.
Why not? Why not?
Because this is intravascular hemolysis, like splenectomy is not needed.
Yes, okay. Regarding the splenectomy, yes, you are correct. Splenectomy is for the intravascular hemolysis. Splenectomy is not necessary. What about the steroids? Why don't you think steroids are effective? Why, guys? These cold agglutinins, right? These cold agglutinins are present in almost all of us, right? Only in some people they are pathologically cold, right? They are pathologically cold agglutinins only in some persons. In those persons only they give rise to this disease. So giving immunosuppression, we cannot get rid of all these cold agglutinins in our body. If we were to give that much of immunosuppression, the person will die of some other disease, right? So immunosuppression, now for the warm antibodies, there are some specific antibodies. When you give the immunosuppression, they will reduce, right? Obviously, immunity will drop a little, but you don't need to give it too much. Here for the cold one, if we are going to give immunosuppression, these cold the cold antibodies, the cold agglutinins, we call them, we have a large number in our body, right? Okay, so to get rid of all of those, we have to do severe immune suppression. So therefore, guys, usually immunosuppression or splenectomy. Splenectomy, you all know why it's not useful, because of the intravascular hemolysis mainly, right? In this cold, these are usually ineffective. Okay. So what is the remaining option we have, guys? Blood transfusion support. Transfusions, again, remember, try to match them as much as possible unless it is a very critical situation and you have no available matched samples, right? Try to match it as much as possible. And these ones, guys, especially for these patients, right? If they are already living in a warmer country, that's fine. If they are, especially in our South Asian countries, where our daily temperatures are like exceeding 30 and our body temperatures are most of the time above 37, right? Then it's fine. You can directly give the blood transfusion. But especially in these cold regions and when it's winter, what we do is, guys, we have to first warm the blood. You use a blood warmer first before doing the transfusion. Why? If you give cold blood, what will happen? Even if it is matched, agglutination, right? Even if it is matched, cold blood will get agglutinated. So you have to use a blood warmer, warm the blood up to 37 degrees, and then you can transfuse it to the patient. Okay. Everyone clear up to this? All good, right? That's it. That's it, guys. Open your documents. We'll quickly go through the questions. Quickly do the questions. Do question number 1. Type the answer in the chat, guys. Question number 1. We have 1. First, do question number 1. Okay, 1 part 1. Send the answers quickly. 1. If everyone gets it correct, so there are 5 people in the class. If everyone gets it correct, I will move on. Quickly do. Nihal, good. Tarinder, good. Excellent. Sharud, good. 2 more answers. Pat. Only 5 in class. Huh? I want the 5 answers. Huh? Who is left? Tajit and Dilshan. Yeah, send the answers. Waiting for you. Guys, 2 more answers. Where? I'm waiting for you. Put it in the chat. Dilshani. Okay, look at this. What did I say was the bestest, most specific test if we are suspecting hemolytic anemia? Always, if the excellent. If the answer has red count anywhere, go with that. Right? Through this mycoplasma antigen, they are good for us for our diagnosis of the entire pathology, what is going on. But if they are asking what is the best test to determine the form of anemia, we go with red count when we are suspecting hemolysis. Do number 2, 1, 2, quickly. Good, Tarinder, good. Nihal, good. Sachit, good. Excellent. 2 more answers. Good. Dilshani, good. Sure, good. Excellent. Cold, huh? This is, now I know this is easy today, after 2 months. Okay, right? Now, because you all remember mycoplasma, okay, right? Okay, look at this. Do question number 2. Question number 2. Good, Tarinder, good. These are the final level questions, final MBBS questions, all of these. So if you're, it doesn't matter even if you're in first year. Good, excellent. Sharud, good. 3 more answers. What happened? Current went. 3 more answers. Sachit, good. Yeah, Nihal, good. Why a question mark, Nihal? What's the issue? Should be very clear. Erythroid will be higher than anything else.
Yeah, but I wasn't sure because the question says findings most likely to be seen. So I thought it might be multiple options.
No. Okay, all of these questions are single best answers. Sorry. Okay, I should have mentioned that. All of these questions are SBA type, single best answer questions. Okay, good. Right. So erythroid will be high. Erythroid will be high. Right. Let's go to question number 3. This one, guys. So I put some questions from our previous chapters as well, just to mix it up. Hoping you all will remember. Question number 3 is not today's chapter, but it's okay. Just do it. Very easy question. Sarinder. Okay. Think again. Sharud, good. Forgotten, huh? It's okay, it's okay. Try. Three more answers. Sarinder, yes. Good, huh? Deshani, again. Try again. One more answer. Who is left? Nihal. What's the answer? What's your? We're waiting. This is fun. Good. Nihal, good. Deshani also good. So everyone corrected it, no? Basically, some went with thalassemia and then corrected it to iron. Guys, this is classic iron deficiency, right? This weight loss, we cannot be specific, but yes, when there is a lot of hemoglobinopathies, we call it failure to thrive with time, right? As the hemoglobin reduces, they can have these manifestations, weight loss, along with the pallor and the anemia and all of that, right? Some constipation can be there, especially if they are taking iron replacements, constipation can be there. Heme positive stools, right? So maybe what is maybe causing this person's iron deficiency? Probably some sort of gastrointestinal bleeding, right? We don't know, we cannot diagnose, not enough information here, right? So the blood picture shows microcytosis, low serum iron, elevated total iron binding. What else do we need here, right? IDA, okay, right. Come here. In thalassemia, especially what did we say? Iron profile for the most part, especially in the traits, right? Will be normal. Only in some very severe cases, in that case, they will give you specifically thalassemia major, very severe case or something like that. Don't confuse that here. Straight away IDA, right? Don't think too much, right? Question number 4. Do 4-1 first. 4-1. Right, good. Tarinder, good. Sharud, good. This hemoglobin, guys. Hemoglobin in a male, we are expecting at least 14 to 17. In a female, we should expect around 12 to 15. Okay, normal levels. If it is less than that, yes, there is some. Yes, Nihal, good. 2 more answers. Deshani, good. Sachit, we are waiting for you. Sachit, quickly. Sachit. Give it a try. Sachit, are you thinking or there is some issue with the keyboard? What's the problem? Yeah. Okay. Look at this. So everyone got it correct. I'm hoping Sachit also got it correct. This is D. Direct Coombs test, very easy, no? Right? Go to the next one. Very easy now. Try again in a few weeks. Okay. Again, this is also very easy, no? Okay. Mycoplasma. Right? Go to question number 5. Question number 5. This is a good question. Good. Deshani, good. Tarinder, good. Yeah, think again. It's directly final MBBS questions. Sachit, think again. They're asking the most likely one, right? Which is the most likely, right? I think we need one more answer. Good, Sharud, good, excellent. Right, look at this. 40-year-old female, Mrs. Sumana, presents with a 3-week history of fatigue and pallor. Not very strong points, but okay. Okay, maybe anemia, can be a million of things. Her daughter has noticed a yellow tinge in her eyes, but she denies darkening of the urine. Very important part in the question. So jaundice is there, but bilirubin is not in the urine. What is this called? Jaundice is there, but bilirubin is not in the urine. Uric jaundice, right? Uric jaundice, right? Okay, then we'll keep reading. So if there is no bilirubin coming into the urine, what can you most likely exclude? Huh?
Extravascular.
Intravascular, you can exclude intravascular. It is highly unlikely that this is an intravascular, right? Unlikely that this is intravascular. So maybe it is extravascular, right? Okay, physical examination reveals mild jaundice. Again, what we talked about, what did we say? In extravascular hemolysis, the jaundice is usually mild, right? Mild, because especially when the hepatic function is normal, right? Lab findings are as follows: HB9, reticulocyte at 8%, indirect bilirubin 2 mg per dl, that's a bit high. Spherocytosis are very important. Spherocytosis in the peripheral smear. Do we see spherocytosis with intravascular? Do we see? Very rarely you will see 1 or 2 here and there, that's it. In extravascular hemolysis, profound spherocytosis will be seen. You will see a lot of spherocytes in the blood sample, right? We talked about this, why this is happening. The young RBCs, they run away, leaving a piece behind, right? Leaving a piece behind. Little by little, they become circular in shape, eggshell-like. And a positive direct antiglobulin test. Why they are giving this? For you to know that it is an autoimmune condition, right? But they haven't asked a question about that. So which of the following is the most likely cause? Extravascular, right? Do the final question, guys. This one is again from another chapter. If just answer this, guys, try to answer this. I didn't stress on this the last class, so just try. Sharud, send your answer again because it got lost in the chat. Tarinda, think again. Yes, Sharud, you're correct. You're correct. It's okay even if I get this wrong because I didn't stress on this that day. I will teach it now. Sharud, good, huh? Yes, Tarinda, yes, good. Devshani, good. Right. 2 more answers, Sachit and Nihal. Nihal, think again, huh? It's okay. I will teach this. Don't worry. Okay. Still, if it's a guess, I'm still not happy with your guess, because if it's a guess, there would have been another diagnosis that you would have gone for. Right. Okay. Right. Okay. Look here, guys. Not calculated. Huh? Okay. Right. A 2-year-old infant, a girl, not a girl, right? A girl is brought to the emergency department after being found unconscious in her bed, right? Okay. She is cyanotic, right? Her respiratory rate is 4. This is very low, guys. Usually, the respiratory rate for a child should be at, it's usually a little bit higher than adults also, right? Her pulse is faint, right? A mother is frantic and unable to provide a history. This happens very commonly. When the child is especially not moving, fainted or something. Mothers also can't talk, can't say anything, right? You cannot communicate easily with them. She does state that her daughter has a bad blood disease. That's a hint, right? Which has necessitated numerous transfusions, right? A blood disease that has necessitated transfusion. Okay. And the mother says this, and this is a 2-year-old child. Highly likely this is some sort of inherited problem, right? Right. Particularly after a round of antibiotic treatment. This is after our antibiotic prophylaxis, guys. We said we have to give prophylactic antibiotics for these patients, right? Despite heroic measures, the child does not survive. Child died. Okay. So a peripheral smear shows severe microcytic hypochromic anemia with target cells. When you hear target cells, what do I want you to think? Thalassemia. Target cells, thalassemia, and poikilocytosis, right? Emergency laboratory results: WBC count 8.5, HB6, which is low, hematocrit at 23. Hematocrit, guys, it should be 45-50%, and in a child it should be 65%, 70% sometimes, 60 to 65% in a very young child, right? Mean corpuscular volume is 55, right? So very small RBC. This is severe microcytosis, right? And reticulocytes at 6%. What is the most likely diagnosis, guys? Look at this. First of all, what I want you all to do, eliminate the traits. Why? What did we say? Traits almost always asymptomatic. In very severe, in some very rare cases, they can show some anemia, some mild anemia. That also mild. But the traits, right? They are usually asymptomatic. Intermedia also we can, guys. Intermedia doesn't usually result in. What did we say about intermedia? Is it a transfusion dependent type? Intermedia, thalassemia. No, we said non-transfusion dependent. So this child has been getting transfusions, numerous transfusions. So highly unlikely this is intermedia as well. Now the problem between these two, HBH and HB bar, right? This is the one I didn't explain to you all in detail that day. Look at this, guys. What is this HBH and HB bar? Both of these are alpha thalassemias, forms of alpha thalassemia, right? HBH disease, what did we say? They have one alpha gene file, but the other three are gone. Right? So commonly what happens, their alpha can bind with some other forms, but preferentially beta start binding together. Beta starts binding with beta. So it becomes 2 beta, right? Basically a 4 beta, right? This 4 beta containing hemoglobin is what we call HBH disease. HBH disease, right? Then what about this HB BART, guys? HB BART is no alphas at all. No alphas at all. So preferentially the gammas join together. So gamma, 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 they join together forming 4 gamma. This 4 gamma chain containing hemoglobin is what we call hemoglobin BART, HB BART. Now, here's the important differentiation we didn't talk about that. HB BART disease, what did we say, guys? Majority of the cases stillborn, right? They are born already dead, they have passed away, right? This is what we call, guys, hydrops fetalis. Then some, in a minority of cases, very rarely, right, they can be born alive, but they will show severe hemolysis. Their bodies will be severely edematous, right? And within a few days, sometimes within few hours, they die. Death, right? Okay, within a few days or within a few hours. Now look at this child, guys. She managed to survive for 2 years. 2 years, true. She had to undergo transfusions. She had to do all of that, but she lived for 2 years. That is the differentiating point here, guys. So this disease is more likely HBH, but she died anyway. Why? Because this is also, guys, this HBH disease also results in failure to thrive. Failure to thrive, because 3 alphas are not there. It's not as severe as obviously hydrops fetalis, but definitely much severe than any form of trait, right? Okay, so HBH sometimes 2, 3, sometimes 4, 5 years they can survive sometimes, and then they die, right? Okay, so this is the difference. I didn't mention this that day, that's why I put this question for you all. Huh? So this is not the BART. Huh? The BART will either be hydrops fetalis, or within a few hours to days maximum, they will be gone. Okay, right? So that's about it, right? I will meet you again on, I think, the 5th, right? And with the next chapter. Did everyone understand today's content? Give me a yes in the chat. Just 5 of you all are there, and just to make sure, right? Yeah, okay, excellent. Right. Awesome. Right? If you all have any question, guys, drop me a message. Right? The next session will be Prashan. He will put the date and the time for y'all. I will meet you all again on, I think, 5th of March. I'm not sure. I'll check the calendar. Right? Okay, then. If you guys have any question, drop a message. Catch you guys in the next one. Okay? See you.
Bye.
Thank you so much.
Right. Bye. No problem.